Good evening, ladies and gentlemen, to tonight's Health and Adult Social Care Overview and Scrutiny Committee. May I first of all welcome Cedric Frederick and Paul Bentley, the Chair and Chief Executive for the ICB. They're in the audience tonight, they're observing, so thank you so much for coming, and we did have a really productive meeting during the week, so I do thank you for attending. Are there any apologies for absence, please?
I will be substituting this evening for Councillor Maritime.
Thank you very much. Councillor Brake?
Yep, thank you, Chair. Two apologies for our colleagues, Councillor Anang and Councillor Clark. Both of them are running late this evening through appointments. But Councillor Anang, I put a smile on my face because the reason he's late is that his GP appointment is behind time.
Okay.
And they will be here later.
Okay, thank you, Councillor Brake.
Thank you.
Okay, item 2 is the election of Vice-Chairperson. Can I request a nomination for Vice-Chair, please? Oh, Councillor Joy?
Thank you, Chair. I'm substituting for Councillor Wildey.
Oh, yeah. Thank you very much, Councillor Joy. Like I say, item 2, election of Vice-Chairperson. Can I request a nomination for Vice-Chair, please?
I would like to nominate Councillor Luella Prenter.
Okay, is that seconded? Okay, seconded. Okay. Any more nominations for Vice-Chair? Okay, is that all agreed? Agreed, thank you. Welcome, Councillor Prenter. Welcome as Vice-Chair this evening. Yeah, thank you. Okay, urgent matters. I don't have any urgent matters. However, I do have something to say which Michael will stop typing now because he'd be a little bit worried of what I'm about to do. But I feel most members in this committee and across the council all recognise the importance of our democratic officers and the support team. They keep us on our toes and make sure we are fully prepared for meetings like today. This meeting just doesn't happen. There is a lot of preparation, organising reports and briefings and meetings, and we are very lucky here in Medway with our Democratic Services team. We have, although, been very lucky to have Michael, a real asset to this council, and he is now retiring. And this is his last meeting this evening. Now, you may not know, Michael will have had 36 years local government service when he retires, all in democratic services, which I would say is quite an achievement. And I would say that Michael's worked for Cumbria County Council, also worked for Sunderland City Council. I can see Michael's wondering where I'll get all this information from. He's already worrying. Northumberland County Council. He joined Medway in November 2014 as the Democratic Services Officer and then became the Principal Democratic Services Officer in August 2021. He supported Business Support ONS Committee, Audit Committee, and more recently HASC and ONS Committee and the Employment Matters Committee too. And he's also led on Scrutiny task group reviews and other projects within the team. It goes without saying he has been excellent at his job, and he has been a big support for our Democratic Services staff, and Wayne, our Democratic Services Manager in particular, he has been an immense support for him, and they will miss him terribly. On a personal level, Michael has helped me tremendously since becoming chair. We have a very open and transparent way of working. I just love it when Michael sits quietly and calmly whilst I often rant and rave. And then he just says something very calm at the end and I just go, oh, and I breathe. Michael, congratulations on a remarkable 36 years of dedicated service. Your commitment, hard work and loyalty have undoubtedly made a significant impact. Your journey is an inspiring example of professionalism and excellence. We all wish you a well-deserved retirement filled with relaxation, joy, golf, and new adventures ahead. You've truly left a lasting legacy here at Medway, and that will be remembered and appreciated for years to come. Congratulations, Michael. Councillor Prenter, can I go to you?
Yeah, thank you, Chair. I think you said everything that needs to be said about Michael, but for me personally, I just want to say thank you. I was on this committee in opposition, and you treated us with respect, even when we was in opposition. No different to you treat us now when we are the administration. When I did have to step up to be Vice Chair, you were very helpful and calmed me down a bit before it and gave me all the things that I needed to successfully Vice Chair at very short notice. So from me, and I'm sure from all the members, thank you very much and good luck in your retirement, Michael.
Thank you, Councillor Printer. Councillor Brake? Not finished yet, Michael.
Thank you, Chair. And Michael, what can I say of you after all of these years of service in local government? As you're aware this evening, Councillor Wildey is unable to be with us, which reminds me, I should have given apologies for David Wildey as well. But that said, David was particularly keen that we be given the opportunity of saying a very big thank you to you for all that you've done over the years in support of us when we were the administration, and also the way you've continued in the role of us being the opposition. You've become a legend in your own time, the truth to be known, Michael, and everybody speaks very highly of you. And I'm not saying that because I've been touting around for saying, come on, somebody, dish some dirt out so we can bring this up at a meeting. That's the farthest thing from my mind, but everybody that has known you, everybody that has worked with you, speaks so very highly of you. And I can only say that on behalf of what is now the opposition within Medway Council, a very big thank you for all the support that you've given us as the opposition, but equally all of what you did for us when we were the administration. We wish you well in your future endeavours. Enjoy your retirement. I'm retired, and believe me, I enjoy it an awful lot. But be careful. You retire, and this is what happens.
Thank you, Councillor Brake. Just briefly, James?
I think just to endorse, Michael, the time, energy, commitment and diligence that you apply to the way in which you support me personally, of course, and my officers has been absolutely outstanding, and just wish you all the best. I'm sure it's not going to be the last time we will see each other, but just you've heard the ringing endorsements from members and others. I don't think there's much more to be said. Brilliant job, and thank you very much for your.
Thank you, James. And finally, Leanne.
It just goes to me to say to you, Michael, well done. It's been a privilege and a pleasure to work with you. And on behalf of corporate management team, our thanks to you. It's you have been a great support to me through periods of change, and it's just been so nice to work with someone at the pinnacle of their career. So well done. Go with our best wishes and good luck.
Thank you, Len. You can say something, Mark, on it.
Well, thanks everyone for those kind words. I'm a bit overwhelmed. I've really enjoyed my time working for Medway Council, and I've enjoyed supporting this committee over the last 4 years nearly. And that's been helped a lot by the sort of the dedication of the members on the committee, in particular the two chairs I've worked with, so Councillor MacDonald and Councillor Wildey, have really put the work and the hours in behind the scenes to make this work. And that makes a massive difference. And I've also been lucky to work with people of the calibre of Leanne and James and Jackie, who's not here tonight, who have always been, incredibly supportive and helpful whenever I've had any problems or issues. So, that's made the job so much more easier than it might have been otherwise. But thanks, everyone. I really appreciate that. Thank you.
Thank you, Michael. And don't forget, Michael, if ever you're bored on a Thursday night or a Tuesday night, you can always follow the link on the Medway Council website. You can watch us if ever you feel you miss us. Okay, moving on then. Can I sign the record of the meeting held on the 18th of January 2024 as a correct record? Is that agreed? Agreed, members? Thank you. Is there any disclosable pecuniary interest or other significant interest or whipping this evening? Councillor Joy.
I'd like to declare another significant interest for item 9, South East Coast Ambulance Service. Thank you.
Thank you, Councillor Joy. Okay, we move on to item 6. Can I just remind members to pull their microphones close to them when they're talking, just for the sound. We've got the primary care, pharmacy, optometry and dental services. as the item. Suk, would you like to introduce yourself and your team, please?
Thank you. Thank you for inviting us this evening to talk about pharmacy and dental services. So to introduce myself, for those of you who haven't met before, my name is Suk Singh. I'm the Director of Primary and Community Care at the ICB. Louise, do you want to introduce yourself and then Caroline?
Thank you. Thank you for inviting us here today. I'm Louise Matthews. I'm the Deputy Director for Primary Care, Pharmacy, Optometry and Dental Delegated Services. Thank you.
Yes, thank you for inviting us. My name's Caroline Battistoni. I'm actually the Secretary of the Kent Local Dental Committee, so representing dentists across the county. I'm also a general dental practitioner myself. I work in West Kent.
Thank you very much and welcome. Suk, are you leading on the presentation? And like I say, some people are having trouble hearing everybody, so we're trying to see if we can do the volume up. If not, can we just make sure we pull the microphones forward? Over to you, Suk.
Great, thank you. We've provided quite a detailed paper, including the pack, but what we thought would be helpful is that we might just talk through a few slides just to bring into focus a few key areas in terms of what we're working on, and areas that might be pertinent to the committee in terms of the questions that you might have. And I'm sure as we go through, we'll have some of the questions that we'll be answering around the paper as well, as we discuss. I thought it was really important to hear from people who work within the professions that we're talking about, which is why we've asked Caroline to join us. And Mark should hopefully be here soon. He's stuck in traffic. But again, it'll be an opportunity to hear from someone that works within community pharmacy about the opportunities and the challenges that they face. What we'll do is that, Louise, if you could go through the community pharmacy aspects and then some of the dental bits, Caroline will do some work as well, and then I'll come back on the strategy. So if I hand over to Louise first.
Thank you. So Mark would have talked about the Community Pharmacy Kent and told you that they were the local representative committee and that they represent the interests of pharmacy contractors in Kent, and they work to highlight local health community where pharmacy can achieve and help with local and national objectives. And he would have talked about how they, in collaboration, help to deliver those services. So I'd just like to talk about two, sorry, could we move the slides on, please? Again, please. The next one. And the next one. Thank you. So I'd just like to talk about Pharmacy First. This is a new advanced service. So an advanced service is a service that contractors choose to deliver as opposed to an essential service, which is a must deliver. This service commenced on the 31st of January, and it replaces two elements of the former community pharmacy consultation service and adds an element around minor illnesses. There are 7 common conditions that this service will cover: sinusitis, sore throat, infection of the middle ear, infected insect bite, impetigo, shingles, and uncomplicated urinary tract infections. Across Kent and Medway, we've got figures that show you how many contractors were formerly involved in the community pharmacy consultation services, and we've only managed to show you for Medway those that have registered for Community Pharmacy First. So what it shows you is that all of the pharmacies are signed up in Medway. And we will be working closely with our colleagues in the local pharmaceutical committee to make sure that we track the referrals and also to make sure that we monitor patient journeys. Could we move to the next slide, please? The other advanced service that's also been introduced recently is Pharmacy Oral Contraception Service. This started on the 24th of April last year, and from the 1st of December includes both the ability to initiate new courses of contraception as well as giving ongoing supply of contraception. And you can see from this that since the 1st of December, 28 out of 52 local pharmacies are signed up to deliver the service. Next slide, please. And again, thank you. So just moving on to dentistry, I just want to talk about some of the things that we're currently doing in terms of planned dentistry commissioning. So we have regular rounds of procurement for mandatory dental services. One of the approaches that we're trialling is we're labelling as rapid commissioning. This allows us hopefully to mobilise in 6 weeks. For Medway, we're literally just about to send out expressions of interest this week via letter to the Medway providers to see whether they're interested in providing additional activity. And we're at this point in time looking for an additional 14,000 units of dental activity. We're also have had funding agreed for 24-25 for the additional hours scheme. This is provided on a sessional basis, and we're looking to expand the cohorts that covers to include expectant nursing mothers and armed forces families. It already covers clinically vulnerable, those requiring dental treatment before undertaking cardiac surgery, cancer patients, care home residents and looked after children. And we've just started to work more closely with public health teams. We've had a meeting with our Medway colleagues to discuss population health management issues and particularly oral health profile and dental needs assessment, whether that's something that collectively we can start to work together on. And we've also got, although this slide is dentistry, but I just thought it was helpful to mention that we also have a duty to respond to the pharmacy and needs assessment that our public health colleagues produced. So I'd then just like to, next slide please, and hand over to Caroline.
Thank you. So I just thought it would be helpful to try to explain some of the issues with access to dentistry from the point of view of providers working at the front line within dentistry. As I said in my introduction, I am the Secretary for the Kent LDC, so we're a statutory NHS body, and we support and represent the interests of dentists across the whole of Kent and Medway. And our biggest sort of challenge and issue at the moment that's affecting our membership that relates to access to dentistry is the workforce issues and the fact that we cannot provide a dental service if we don't have a workforce to do it. And that's not just dentists, it's also dental care professionals who support dentists. And we need to look for ways to work around that. The difficulties are largely driven by the national contract, which we can't necessarily change locally. But it's not just about money, it's about the dental workforce needing to feel valued, needing to feel part of the NHS family, and looking at ways that we can make local change. We're very fortunate that we're working very closely with our colleagues in the ICB who've been very supportive, and we're looking for ways to try and improve the issues with the workforce. The other issue that we face that I think is worth drawing some attention to is a lack of understanding amongst those from outside of dentistry about what to expect from dental services, which creates challenges for the profession because people are often questioning us on the way that we're doing things when we are following the contract as it's set. And that takes up a lot of time, but also makes it difficult for people to understand why services are not available to them. I'll pass back to Suk.
Thank you. Could we go to the next slide, please? And then the next one. So I kind of wanted to bring this back into, I guess, what we're doing with our primary care strategy, because I think we've heard a lot. So we did an extensive engagement exercise around primary care, and it'll be no surprise, actually, one of the biggest things that we did hear about was access generally. So whether we're talking about general practice services, pharmacy services, or dental services, it's around how people can get access to those services. It was also really helpful to hear from people who work within those professions as well. So as Caroline's kind of alluded to, it's actually quite useful to understand the perspective of those that work within the profession about what the challenges might be, but also what the opportunities are. So how can we really do something to support the workforce, to grow the workforce, to offer an educational environment, training needs and developments. Could I go to the next slide, please? When, and again, it's not to duplicate what Louise has spoken about, but when we're looking at the work around community pharmacy, we've just popped in a case study of, particularly within Medway. So we've had Maritime Health Partnership. that have really utilised community pharmacy for their patients to the benefit of their population. And that's all about relationships. So they've built a really strong relationship with the local pharmacy. They've worked together. They've made sure that it's an effective pathway. And again, really communicated that out to their patients and built that confidence and trust with the population in terms of what community pharmacy can offer to them. From a perspective of what we're doing strategically, and I'll introduce Mark in a minute, who's arrived from the Pharmaceutical Committee, is that we really want to see what we can do to drive services within community pharmacy, build confidence and trust with people in terms of accessing them. But the other thing we recognise is that community pharmacies are really accessible for the patient population as well, so they're really embedded within local communities. So there's a real good opportunity around community pharmacy and how we can engage patients and support them. Could I go to the next slide, please? So we mentioned obviously the challenges around dental capacity and some of the challenges that we have got. So one of the things that we are doing is a really targeted approach around commissioning additional capacity in dental. So a particular focus on areas of high deprivation. And we've kind of put in the slide there about the local authority areas that we'll be focused on. And actually, in terms of the main beneficiary of additional capacity, it would be Medway. So that's our targeted approach. We really want to try and increase the units of dentistry activity within those areas, which also would then drive an increased NHS dental workforce in those areas. But again, it's a broader piece of what we need to do to make sure that that workforce feels valued and part of that community. The other thing I kind of wanted to mention as well is what Louise mentioned earlier on, is it's around partnership working. So actually what we want to do is just, and we've already started those conversations working with James and his team within the public health team, is actually how can we really make sure that we get the focus on not just the access, but the prevention as well. So the oral health needs, making sure that we meet needs of our population and really do structure the work that we do from an ICB perspective, really closely aligned with that from the public health perspective as well. I'll stop there. If Mark can just quickly introduce himself and then we can go back to you, Councillor MacDonald.
Thank you, Suk. Sincere apologies for being a little bit late. I'm very sorry to be late. Community pharmacy have gone through quite a journey, I would say. And I suppose one would say we are the heart of the community. And we should really be looking at local. And I have to say the great work that ICB have done in terms of harnessing that collaborative working between our general practice colleagues and our dental colleagues has been exemplary. If you think about access from our general practice surgeries, it's great to see the level of communication that is currently happening. That wasn't happening previously. And this is something we should really be proud of, where a general practitioner can refer patients that needs that support to their local pharmacy. And pharmacists being able to be enabled to provide antibiotics for people that really need it, I think that's really innovative. And a lot of our colleagues are really excited about this proposition. Several years, well, it's been quite some time back where pharmacists have been recognized in terms of being able to utilize their full skills as healthcare practitioners. And I spent a bit of time educating colleagues about community pharmacists being clinicians that can be able to assess those patients and provide them with adequate care. With the introduction of some of the key initiatives like Pharmacy First, we're able to actually treat patients. Previously, we had to refer people back to the system, whether it's A&E or back to NHS 111 or back to general practice. But being able to treat people fully with confidence is something that I think we should all be really proud of. As an organization, we also worked really hard to enable pharmacists by giving them adequate training to be able to be confident in looking after those patients as they walk through the door. And I think that's something we worked really hard on. And I also want to thank the ICB for sponsoring one of the training events. We've trained over 295 pharmacists, really, across Kent and Medway. And that means that when people are being seen in those clinical settings of community pharmacy, they are rest assured that they're going to be getting the adequate care that they need. And the report that we've seen so far has been also quite good. We're not seeing any mistreatments or any errors that is, something that when something starts initially, you will see that teething problems. is actually been going quite well. And what is also good is that we're working closely with our primary care colleagues in the ICB to really track those referrals as they go through individual pharmacies to ensure that those referrals are being looked at very quickly and actioned very quickly as well. And that will obviously continue to help the patient journey. So there are quite a number of work streams we're doing to continue to reassure the system and also to ensure that people are getting the adequate care that they need, and also continue to improve access. And I'm more about local. It's only local that will win. Community pharmacies are at the heart of our communities. Access is a lot better, and it will help our coastal areas as well, where health inequality is an issue. So we need to really continue to utilize that workforce in helping address health needs of our local population.
Thank you, Mark. Thank you. Just before we move on, Scott, did you want to say anything about public health and pharmacies and dental?
Yes, thank you, Chair. So we do have, in the paper there's made reference in terms of the importance around prevention. In Medway we've got a really long positive track record working with local pharmacists. We have some exemplars across the South East of how they support many agendas, from health checks to smoking. Recent examples being a really good promo around Know Your Numbers, blood pressure months last month. We're hoping to repeat it in June. We'll come back out and test as many members as we can, hopefully before a meeting and afterwards. And in terms of our oral health work, obviously prevention is a key part of what we do. And our oral health strategy that was co-designed with various NHS groups, really looking for continuous support from all partners within the NHS across councillors. We've been talking about it at Blythe School and how we integrate those key messages, and three critical messages around prevention of oral health, around regular toothbrushing, thinking about how many sugars enter your mouth, and access to dentistry. And obviously this is a really critical aspect in how it links with the work that Suk's explained.
Thank you, Scott. Before we move on to questions, can I just, we've lost one of our members who's feeling unwell, so you would have seen a bit of discussion going on with myself and the Democratic Service Officers. One of our members has just excused herself from the meeting, just so you know. Suk, I'm going to go out to members, but I think before I do, I'm going to say, thank you for the PowerPoint, because you did do that, and I'm really appreciative of all the report. It's a good report, as it always is. You will remember I am surprised we can't get waiting lists from our dentists in Medway. We're not talking about hundreds of dentists here, we're talking about a few dentists. And if I would have known we couldn't have got the waiting list this evening, I told you, out of pre-agenda, I would have rung them myself to find out who's open for NHS and who isn't in Medway. And I suspect that not many are open, or there are none open at the moment in Medway for that. But I'll touch on that when I come to my questions. You don't need that, but I did want to register that we will note that with the Vice Chair when we wrap up, that we are slightly disappointed. I know there's going to be reasons which I'm sure you're going to come back to, but I still don't really understand why we can't get that information. Members, Councillor Printer.
Yeah, thank you. I'm sure everyone in this room could say a story about trying to get an NHS dentist, even if you're registered one, trying to even get treatment. Myself, last week, it was a difference between 18 months or pay private and see them tomorrow. I was in pain. I could find that money and pay for it, but not everyone can. I actually have opened an email that I received today from someone who's trying to fight for their grandson, who's in an NHS dentist and cannot get an appointment while their child is in pain. Just looking at your report, 2/3 of dentists at one point were going to give back their contracts. What have we done to really alleviate that? Is that still the case? Are we waiting for that to happen at any moment again? And also, in the report, this new patient premium, exactly how does that work? Because it says that if you've not seen an NHS dentist for 12 months, I believe it is. Well, when I rung and said I haven't got an NHS dentist, they never collected my data to say, well, when did you last see an NHS dentist? To have that data, to know who to go to. And I'm not suggesting that I should be at that top of the list, but there'll be more people in more need than me that maybe, if they're not harvesting that data from me when I last saw an NHS dentist, then who are they? How are they collecting that data to then use that funding that you've got at nearly £200,000? Thank you.
Thank you, Councillor Printer.
So I was going to say, Louise, do you want to cover the bit around the new patient premium? And then I think there's just a general thing we might want to cover around registering with a dentist and the waiting list. I think just to explain a bit of the context around it. I know we'll come back to it at the end, but I think it's just a bit of the background about how dentistry works.
Okay, we'll try and cover the questions between us, if that's okay. So the new patient premium, it's looking for access to patients that have not seen a dentist in 2 years. That hasn't yet gone live in all areas, so you may or may not have been asked that. It will be paid on a credit basis, so contractors are required to perform a certain amount of activity, and that will be credited on that activity. So if they are given a contract, say, with 100 units of dental activity, and they are seeing a new patient, and that is, say, 3 or 5 units, then that would come off that total. They don't get an extra payment, it just deliver their activity quicker.
Yeah, sorry, if I can just, sorry, maybe I'm not quite, so that's for the dentist-led, just when they treat a new patient, not really to go and find new patients, but if they just happen to fall upon a new patient, they get extra credits. So it's not really to go out there and find these people who haven't seen a dentist for over a year, 2 years. All right.
It's sort of triage when they ring up. That's one of the questions they will ask the patients. That's how it will be. It's not proactively seeking.
Can I just add on that? Because it's a brand new initiative, so we're still finding our feet with how it's working. Probably the reason you weren't asked whether you'd been seen or not is it's a per practice relationship. So it's actually whether you've been seen at that practice within the last, I think it's actually 24 months. So they will know that because they'll know from their records whether you've been seen. And actually, one of the strange things about the system is if you've been seen at another practice down the road 6 weeks ago, you will still attract that new patient premium at the new practice that you go to. Because that's how it's being done, and it's being done, paid, as Lou says, after we submit the claim. It can be seen by the NHS Business Services Authority, who process and make our payments. They can see whether the patient has been seen in our practice in the last 24 months, and they will add a credit on if the patient hasn't been seen.
Sorry, Chair. Even if they've been seen privately, that gets picked up? Or is it only if they've used an NHS within the last 24 months?
It's only NHS, because we don't submit details of private claims to the Business Services Authority.
Councillor Printer, you content? Answers? Yeah. No. Councillor Campbell?
Thank you. There you go. Thank you for the report. I want to unpick a little bit about the part where you're talking about the NHS dental contract reform. There's a few measures here. Some of the reforms, it says, was announced in July 2022. There was a recent announcement then from government in February this year. So there's a few things here. So more funding announced by the government in February. But when I read your report, distilling it down to a Medway scene, there doesn't seem to be much coming our way. So it's a big announcement, £200 million investment fund, but we're not seeing any of that. And the mobile dental van, the NHS-led initiatives like the mobile dental van, that's not coming to Medway. There's a few things here. So what is your honest opinion of these NHS-led and government-led reform plans and investment? What do you honestly see in terms of how Medway people are going to benefit from that? Thank you.
So I think there's that in itself is not going to address the issues that we've got around access to dentistry. It helps. So there's things around increasing the rate of units of dentistry activity and the price that we pay for that, and equalising that is as an important thing to do. That might help. But this on its own is not going to be the answer to the challenge that we've got around access, which is why I say the approach also as an ICB that we take is really important. So how do we really focus on the areas and it particularly, I guess, focused around health inequalities to drive activity in those areas. The thing that we mentioned about dentists handing back contracts, actually we need to understand why that is, and actually what can we do locally. And I think, as Caroline mentioned, how can we make sure that people who work within NHS dentistry feel valued as part of the NHS family. So there's some work that we've got to do around recruitment, retention initiatives. I think also there's a bit of learning for stuff that we do with general practice. There's a whole plethora of support that we do. So we did the attraction package, for example, within general practice. It's actually, what are the opportunities about extending those offers into community pharmacy or dentistry as well. So I think there's stuff that we need to do locally, and that's part of what we've obviously kind of announced in terms of what we're doing around the strategy work, which will help us to try and really focus on what it will mean for Medway. And that's the kind of last slide I wanted to kind of focus on, is that if we do really target our approach around our areas and what we want to do in terms of increasing numbers of units of dentistry activity, Medway would be the biggest beneficiary of that, because there's some real challenges that we recognise within Medway that we need to try and address. But these national ambitions help, but they in themselves will not be the answer to the challenges that we've got.
Sure, I understand that, but if there are national initiatives and national funding being announced, why aren't we getting it in Medway? What's happening here that we are not being considered for it, or that's not distilling down to us?
So and I think I put it on the last slide, I think when we look at us as a system in terms of the amount of dentistry activity that we have in Kent and Medway, we have higher than the national average. And I know it may not feel like that from the patient population perspective, but I think within mobile dental vans, it was really focused on the areas where there are no dental practices. And that isn't, and when they've identified that nationally, Kent and Medway have not been identified. I'm just checking, Louise, that's correct, isn't it? So when they've looked at it nationally, I think that just shows that there's a national problem, and I think this isn't necessarily just a local one. But when they've looked at it nationally, Kent and Medway hasn't been identified as an area which would be eligible for the mobile dental vans.
Thank you, Councillor Campbell. Councillor Jackson.
Hello, thanks, Chair. I just wanted to start off with, I've had experience of community pharmacies, and I think that it's a really good idea, and I'm all for local. But I'm a bit worried about what Councillor Prenter just said about children not being able to access NHS dentists. I'm all for prevention, and but as a foster carer, it was like one of our needs that our children must be seen by the dentist, you know, at their annual reviews or even twice. And I feel that we really want our children to matter in Medway, and if our children aren't getting access to NHS dentists, that's really worrying. I mean, that's quite shocking, and I didn't even realise, I thought that every child, I mean, I know adults are, you know, but that's really, really worrying to me. And is that the case, really, is what I'm asking? Is that the case that children are going without seeing dentists, and you've got no waiting list of evidence that children are waiting to see a dentist?
So I'll try to come back on this. Obviously, it's horrifying to us as dentists that we can't provide the service. And I think can't underline enough how much this is a national problem. It's because the national dental contract doesn't provide enough funding for the entire population to see an NHS dentist. That's what it comes down to. And it's what we're saying in this area, actually, we're doing better than a lot of areas. So yes, it may not be brilliant here, but it's better than it is elsewhere. The picture's very variable because dental practices are effectively private businesses that carry out NHS contracts. And so it's very difficult to force practices to do something that's not explicit within the contract. What you will find is there are a lot of practices out there who routinely do take on all children. So I work in one. Often we don't have capacity to take on adults, but whenever we have a child 16 or under and parents want to bring them in, we will always make space for them. The knock-on effect of that is often we have less space for adults because we are given a finite amount of funding in a year. if we continue to see patients over and above that, we don't get paid. And that's, you know, we care about the health of our population, but we do still need to meet a bottom line. Unfortunately, there are some practices that struggle so much with capacity that even to take on children is just a huge challenge for them. And they have to wait until a period of time has passed till they have more capacity to take on more children. We also struggle that if it becomes known that a particular practice is taking a particular section of the population on, you get queues outside, you get riots, you get the receptionists being attacked to get patients on. So it's a very difficult balance. But the root of the problem comes from the national contract and that there isn't provision for all children to be seen. It's not a requirement for us to see all children. And locally, all we can do is our best to promote and change that. We can't change the national contract.
I totally understand it's not, and I wasn't having a go at you. I was like just shocked that this is nationally as well. Like we've come to this. But I suppose my next question is how do we go about recruiting, and what I suppose the question is what do we do, or what can anyone do to make you feel more valued and part of the NHS, and to try and sort this mess out?
Do you want to think about that one, Caroline, and come back?
I probably do want to think about that one. I mean, changing the national contract. What we can do locally is a work in progress. So we're already, progressing things to integrate dental services with the rest of primary care, to look at ways to support the workforce to feel more valued. Because as I said at the beginning, it's not just about money, it's not just about paying dentists more, it's about the support systems around that to make them want to stay when there are all the difficulties that come along with working in the NHS. So it's something that is in progress that we're working on and looking at ways to tackle.
Thank you.
I've got Leanne, then I've got Councillor Bray.
Thank you. I was just wondering what other factors may come into play around dentistry, because dental workforce recruitment and retention is the #1 issue, but in terms of the presentation, which I found really helpful. But I think there's more to this than the national contract or the number of UDAs. So, for example, the General Dental Council, newly qualified dentists waiting longer than a year to get their number. Then they're waiting another year to get their NHS performer numbers. And I think that's where, the newly qualified dentists are getting fed up with the systems and how long it takes. And then they look to overseas, and then they leave the NHS and they leave this country. And they go elsewhere, like New Zealand, for example, because they're onboarded pretty quickly and the systems are working. So I think that there's something happening earlier on, and just the length of delays to actually onboard these newly qualified dentists is pretty unacceptable. So I was wondering what the Kent Local Dental Committee has done about that, really, because it is an issue. Thanks.
So I'm not directly the best person to actually answer that question, but I can come back to you with more information on it if you want, because I know the person to speak to. What I can say is that the issue is mainly actually with overseas qualified dentists who aren't always automatically allowed to join the GDC register. So the GDC register being not a local problem. The GDC are addressing that. That's one of the things that they're looking to do, is to get them onto the register faster. Locally, it's more an issue of getting performer numbers, particularly for overseas qualified dentists. So performer numbers are what enable dentists to do NHS work. And there have been some recent changes to really speed that process up. In fact, one of our members on the local dental committee has been very heavily involved in that work, and that's why I can come back to you with more detail if you would like it, to sort of update on the progress of that. But that's something that, again, it's a problem in addressing recruitment and retention, so it's something that we've been working on.
Thanks, Caroline. We're asked the Vice Chair to put that down as a... If we can have a briefing paper, that'd be really good, just for members. That'd be brilliant. Thank you very much, sir. Councillor Brake.
Thank you, Chairman. I think that an awful lot has been said about dentistry this evening, and I have nothing further to add to what has already been said, because there's a lot of outstanding issues and questions that have been raised, so I'm just going to leave dentistry there. However, the area that I would like to talk about, in fact, is pharmacy, if I may, please, in as much as that I think we've seen a significant development of pharmacies. We've seen a significant development of the work that they do, the input into community facilities and community service. Examples such as we've seen since COVID hit us, that our pharmacies have been involved in vaccination for COVID and updating patients within the community. Flu, influenza, shingles. They now do blood pressure checking, and of course the latest will be the oral contraception, which goes live next month. So there's an awful lot that's going on out there in the community for the direct benefit of the community, which obviously relieves a lot of pressure on our local GPs, which is all to the good. But there's nowhere in any of the reports that I've read, and even the presentation this evening, this is really good work that's being done, but this is almost like the analogy of there's nothing like a free dinner, and nobody seems to be talking about how much is this costing. Now, I'm hoping that you're going to turn around to me and say, well, there's no additional cost in what the pharmacists are providing, in which case I'll be the first to stand up and applaud the work that they're doing. But something is niggling in the back of my mind that says this must be costing the community, this must be costing the NHS, this must be costing someone somewhere money. How much is this actually costing, please? Thank you.
Okay. Thank you for a lot of those comments. I think the work that's happened, especially during COVID, has really humbled the sector, and we were very keen to continue to support our local population, especially with the addition of LFTs, so lateral flow tests, where the vulnerable patient can have access to the COVID test kits. That's absolutely incredible to see. Just want to touch on the point that you are quite right, there is always barriers, and one of the issues we're facing is around dispensing our medication. Most of the time we dispense at a loss because we've got a tariff. So we purchase medicine on behalf of the government, and we get reimbursed by the government from that. So what has happened is that the government has taken some money away from that margin we get from medication being reimbursed, and they put that money into service provision. So that's the shift that has happened. So these services have been commissioned nationally. So the government announced a 625 million negotiation, which happened last year. This is where the pot of money for these services is coming from, really. So that's been negotiated last year, and it's an additional funding into community pharmacy. But the issue we have is the tariff we're getting for the items we're dispensing, those paracetamols we're dispensing, is a lot less than what we usually are getting paid, and sometimes contractors are dispensing at a loss. And this is a massive issue for us. And since, the good old saying of Brexit really added additional pressure on the supply chain as well. So, and obviously being able to produce some of those raw material required to make those medicines becomes quite challenging for the manufacturers to be able to source those products. So all that is adding an impact in the amount of money we're paying to be able to source those medications in our pharmacies. And this is where you see a lot of drug shortages impacting a lot of people in our community, where you can find a particular medication. You've got to go around different areas to try and source those medicines. And that's the impact we have, and one of the challenges that we're currently facing.
Thank you, Councillor Brake. Councillor Hamilton. Councillor? Oh, Scott. Go ahead.
Yeah.
And just to add to what Mark was saying, in terms of one of the questions around who's funding some of the enhanced services, so there's no such thing as a free dinner. In terms of some of the enhanced services, such as the health checks program that we've been piloting in pharmacies, a lot of the good work they do around supporting people to quit smoking. So to be a real direct answer, some of that's all that's funded out of the public health grant, but that's a conscious thing. That is budgeted. That's what we want. We want to use the public health grant for that. So if we don't have primary care professionals who are in a similar situation with dentistry, where there's a high demand, there is capacity, actually rediverting some of that public health grant to fund pharmacists and pharmacy technicians to be able to do some of that prevention work does alleviate that other pressure that exists in primary care. So that's an intentional spend to fund that thing, which is an intentional budgeted part of the public health programme.
Thank you, Scott. Councillor Brake, do you want to come back?
Yes, if I may. Thank you, Chairman. Thank you very much for the response, Mark, and also Scott for your additional information. I think for the benefit of Medway, it would be interesting to know, and I don't expect you to come up with a figure off the top of your head tonight, but I do think it would be very useful if we were to have sight of information relative to Medway as to the number of hours, units, however it's may be put into the public domain, of how much time is actually spent by pharmacists actually advising the local community, and how much does that actually cost the people in Medway. And I do believe that if we can start collating information like that, we then may be able to see the benefits that pharmacies are contributing to Medway, and the time that potentially is being saved on GP practices. Would you agree with that, Chairman? That being an interesting and worthwhile piece of information that it would be worth us having?
I think so.
This can be included in the Vice Chairman.
Yep, certainly. Michael's got the word in, so I think if we can add some of that in, Michael, we can remind him when we get to the things.
Thank you.
Thanks, Councillor Brake. Councillor Hamilton.
Thank you, Chair. So I've got a number of questions. This is also my first time on the committee, so bear with me. The first one relates to pharmacists. So in your table, you stated that 52, so all pharmacists in Medway, are signed up to Pharmacy First. I noticed, however, that only just over 50% of the CM pharmacists provide contraceptive services. What geographical gaps do we have in terms of that service provision across the pharmacies in Medway? And what work is being done to onboard more pharmacies to provide those services? That's question one. Question two is returning to Councillor Prenter's comments about the new patient premium. So I was listening carefully, and to me, this seems like it's a totally inefficient approach. If only new patients at a particular practice are going to be counted in this, to me, that makes absolutely no sense. You're not checking whether they have accessed private services or if they have accessed other dental services on the NHS. To me, on a really basic level, that's completely inefficient. How will the patient premium actually tackle access to NHS dental services given this, it's just ridiculous, actually. It's not providing any more services. So what and how can it actually increase access to NHS dental services? The next one is in terms of, we have at the council been very successful in growing our own numbers of social workers through many initiatives here. What is the relationship with Medway School of Pharmacy, and how are you looking to grow our own here in Medway so that we are starting to tackle the chronic recruitment and retention issues that we've got in dentistry? And the last one goes around complete lack of transparency around waiting lists. It's not acceptable. It might be private businesses, but those businesses are providing NHS services. And I'm particularly concerned that we do not have data around how many children are waiting to access dental services. And I'd like to see a solution to that and some suggestions around solutions so that we can get transparency around the actual waiting lists across Medway.
Thank you, Councillor Hamilton. Just a word, really good. I hope you've got all of them, and Councillor Hamilton will be able to come back to you with the questions again. Just to remind members a couple of things, because it's been a few members tonight. We're not supposed to be discussing children this evening, so we are sticking to adults. But it's good points around the children, especially around. But I just want to remind members of that. And a really good point about the waiting list, because I will be coming onto the waiting list when I come to my part.
I want to come. Can I come back on the children? So the reason why I want to see the children is that we are building up a huge problem for the adult population as they transition from being children to adults. So whilst it's not about children tonight, it has a knock-on.
I totally agree with you, Councillor Hamilton, and I actually think it might be something that we can explore at the end with Leanne and with James with regarding maybe a theme between us and children's ONS. James, did you want to come in on that?
Well, just very briefly in terms of, I think, I know we're not meant to be talking about the children, but I think Scott referenced the work that we do around our oral health strategy that is quite specifically focused on children, but I do hear and understand what you talked about in terms of service access, because it's a slightly different pathway, I think, and the interventions that we're trying to do with children is to do the preventative stuff, but I do hear what you're saying. And then the only other bit which I can answer, I think, in terms of the relationship with the School of Pharmacy, because I actually sit on the committee, so I can say that there's quite a lot of work that's been done with the Medway School of Pharmacy in partnership terms, both with the local authority and the ICB.
And totally correct, Councillor Hamilton, around the transition from children to adulthood. We can touch on that one, so we can. Over to you, members.
Thank you. I'll take the first question. So, contraceptive service was launched in two phases. One was Tier 1, which is the continuation of existing people that are on existing oral contraception. And Tier 2 is initiation of oral contraceptive pill. So what has happened is that we have, you're quite right, there is we've got to be able to understand where the gaps are. So we have built a map that you can actually be able to access, type in your postcode, you know exactly where to go in terms of locating your nearest pharmacy that provide the service. They had up until end of February to express an interest. So that's happened. So what I'm trying to say is that quite a number, I think we've got about 68 across the county. I need to check the number for Medway specifically that are providing this service. We've also worked with our local sexual health service to ensure that the pathway is very clear, so we can continue to ease the burden from our general practice colleagues and also from sexual health clinics, so people can be able to, those that are, have been on oral contraceptive pill, they're very stable, can easily walk into a community pharmacy and access them. They've also looked at the number of, the quantity they can access. So they can, if it's the initiation, they access the 3 months. If it's something they've been on for quite some time, they can access up to 12 months supply. So that then takes that patient out of the system in terms of them being able to manage themselves and look after themselves out in the community. So that has worked really well. But I've got to say that a lot of patients we've spoken to are quite pleased about this. And what is great as well is that a young person or an individual can access their sexual health needs in one vicinity. So if it's emergency oral contraception, chlamydia treatment, and obviously contraceptive pill, they can access it in one vicinity, which is, to me, is a good news story. So it's a journey, as I said, and we continue to monitor the training needs of pharmacists. So we focused heavily on pharmacy first to get everyone across the line. Because we've got people trained, that gives them confidence and to be able to provide a service. The next thing we're going to do is to then get everyone out and give them additional training and upskill those out in the community as well, to give them the confidence to be able to continue to provide the service. And that's something I continue to work with my colleagues at the ICB.
Just to come back on that, I would like to know where the geographical gaps are at the moment, because accessing this is really important for people sometimes pretty quickly.
Totally understand, yeah.
Yeah, and I think we can provide that as well. Just quickly want to go back on a couple of things as well that you mentioned. So the new patient premium, so obviously this is a new thing that's come down nationally. I think we have to monitor it, see actually what the impact is. I think with all these things that we've kind of mentioned that's come down, there's an offer there, and actually we just need to see actually what the benefit, the value of it is. And it might be that, again, this is something that we could put back as a briefing to say actually what it's meant for Medway in terms of the access and how it's kind of helped with some of the challenges people are experiencing.
Yes, but if you're only monitoring in the actual practice, you're not going to be able to get concrete data to say whether that is actually a new patient or not, because that person might have accessed another NHS dentist where that data will not be available, and the same with the private dental access. So for me, it's got to be very concrete, data-driven. Yes, I am a new NHS dental patient, or you've got to find a way of tracking, has that person accessed an NHS dentist in another practice or private practice? It can't just be what you're getting from that actual practice.
So I think the join-up will be there for the NHS, if I'm correct, through the system. So there would be, so you wouldn't just be in that practice, but if you've accessed, it's the NHS bit. But I think what Caroline was referring to is obviously the private bit doesn't go through the same portal. So there's an element of actually the dental NHS access we can actually track. So that's what we would be able to provide. The thing around waiting lists, and I'm not going to preempt, I think, what you're going to ask, but I think I recognise the ask, and I think obviously the challenge we've got is that there isn't a registered list with a dentist. You don't have a boundary like a catchment area like you do with GP practices. In fact, we've had an example of a patient that's coming from outside of Kent and Medway to access services in Medway because there isn't a geographical boundary, because actually they found it easy to access services here. And that's a real life example that we've had. But I think one of the things that we could be looking at is actually a piece of work that we do that actually just tries to get, and I guess linked to that kind of needs assessment, is there is some work that we can do actually to try and actually understand what the need is, what the demand is that's coming through, and how we are meeting that for the different groups. So there are children, pregnant women, other exempt groups who should be able to access NHS dentistry, and then that helps us inform what we might need to do in terms of actions to try and address that. But we can maybe talk about that at the end in terms of how we can pull that together.
I think Councillor Hamilton brought up a good point, and it's the point I brought up at the very beginning, so we will touch on it when it comes back to me, and I'm sure other members will join in. Councillor Joy.
Thank you, Chair. Again, I'm going to go back to the dentistry. Looking at the figures where you commissioned units of dental activity, over the last 2 years, going at your 96% figure, 1.1 million units of dental activity have not been completed at that 96%, which is quite a considerable amount. If you also take in the year of COVID, you're up to 2.6 million. If you look at that figures for Medway, which is between 16 and 17%, it's 166,000 over the last 2 years have not been delivered. And looking at the fees of £30.23, that's £5 million worth of funding that was allocated to this. And there doesn't seem to be any effort to try and deliver that numbers. Yeah, it'd be great if it'd be Kent, but I'm more worried about the residents in Medway. With that potentially £5 million of funding, and what can be done using that funding to try and encourage more dentists into Medway. Looking at the numbers this year, you've had contracts given back of 23,000. You did say when you were presenting that you managed to issue another 14,000 units in Medway alone. That still leaves us a shortage of another 8,000. So if you look at the amount that was funded since before COVID, £12.5 million has not been spent in Medway. And has that money been ring-fenced to make sure it's given towards the residents of Medway to provide this dental service? Because we've got young adults now that were children going into COVID that have probably not seen a dentist as they've gone in, becoming 18, 19, 20, and the possibility is they're not going to see a dentist into their early 20s. So we need to make sure that we're getting them people seen, because like Councillor Hamilton said, if we can get it right with the younger age group, it's going to save a lot of money at a longer term. So we're just looking at the one unit, but when you go into some of the higher levels where a lot more units are paid, it can be quite costly. So can you just say what is being done with that funding that's not been used?
Yeah, sure. So what happens is that we commission units of dentistry activity, and those that aren't delivered, there is a process called clawback, where the money then comes back for those units that have been delivered. And then we can then reinvest that into dental services. What we are doing is an exercise that we're doing about rebaselining some of the contracts, so where we've got some providers that have significantly not delivered, I guess, against what they've been commissioned, is that we want to try and rebaseline the contracts, and then we then have more money that we can potentially then invest into dental services. The dental money is ring-fenced against dentistry, so we actually have the ability to make sure that it's invested in the right way. And I think that last slide that I was just trying to say is that where we do invest it is we need to be focused in terms of targeted areas, and in the local authority areas with the highest areas of deprivation, we want to commission more units of dentistry per head of population. And so obviously from a Medway perspective, that would be quite significant in terms of what we could do around that. So that's the commissioning approach that we take. Louise, is there anything else that you wanted to add in terms of the approach around commissioning?
Just to say on the rebasing that you mentioned, the government needs to enact some regulations, and they won't come into effect till October. So that's in our plans for this year. But there is a mid-year and a year-end review process that takes place. The contract providers are paid monthly in advance, and that mid-year and year-end review process basically does an analysis of what they've been contracted for and the activity they delivered. So that is a really complicated calculation, but it looks at how much money we claw back from the individual patients. I'm afraid your calculations were a little bit convoluted, and I guess it's just a little bit complicated in terms of all of these figures, and not all of the units are paid at the same price. So maybe we could come back with a bit more around the financial side at another meeting.
Thank you, Councillor Joy. I'm getting a feeling that the briefing is going to be so big it'll probably be another visit from you back at this committee very soon, the way it's going. Can I remind members going to Councillor Cook? Can we it's the questions. I know our time's moving on, so we can do the questions. That's great.
Yeah, thank you, Chair. I'll just ask two things that I think haven't been drawn out yet. One is I was really pleased our Director of Public Health, when James, you mentioned the oral health strategy. I recognise what's been said about children, but keen to hear a little bit more about how that work is, assess the impact of that, how we're certain we're doing the right things. Particularly pleased to see the work with our military personnel and the ladies and nights activity. And then just a question I felt we hadn't asked yet around the rapid commissioning of the UDAs in the areas of highest need that was picked up on in the presentation. The analysis from Canterbury in phase 1 and what the learnings were very briefly on that. And then very conscious that Medway is the largest recipient there. I'm wondering if that's because Medway's need is greater, because obviously the need, the index, the IMD ranking. And we've heard that we've not been eligible for some of the funding because, it seems we've heard this is a national problem. Some areas are worse, but I'm wondering, is Medway one of the areas in worst situation in Kent? In which case, are we missing out on funding because of a ranking regionally? Thank you, Chair.
Thank you, Councillor.
So on the rapid commissioning, we had really positive feedback from the pilot we did in Canterbury. It allowed us to offer tailored amounts of activity, so the providers could tell us what they could cope with, what was relevant to the workforce they actually could tap into, and it also enabled most of the providers to bring that activity on board much quicker, whereas if we do a full procurement exercise, which we did last year, some of those contracts took 12 to 18 months to mobilise. There is also a delay, so I mentioned that the finance is complicated and the clawback process is complicated, but we don't get that money instantly. What we claw back this year, we get in the budgets for next year. So we're always paying catch up in terms of what we're commissioning. So that's why the numbers that we're looking at in that rapid commissioning for Medway don't match that 23,000 figure. Sorry, there was the last question that you said. I was just going to come on that. I forgot.
Are the numbers higher for Medway because Medway's in the highest need across the whole of Medway and Kent?
So, data around dental is complicated in that we don't hold the data. The data is held by the Business Service Authority on behalf of NHS England. So, it's a convoluted process to get the data out, and that's something we're trying to tackle. But we know from a Kent and Medway figures that we do have, Medway is one of the more areas in need. We don't have the figures that the national teams would have looked at for the reforms. We're still hopeful that we might see some of those 240 golden hellos coming our way, but we're also looking at our own kind of approach to dental investment, and we're also considering whether we could bring in some more clinical leadership around dentistry to help us have that stronger voice on that national picture.
Scott, did you want to come in quickly on that?
Just on your first point around the oral health strategy actions, and I'll focus on the parents because it's an adult board. So I'm pleased you picked up on that. One of the critical things that we do around oral health around parents and older people is around training. So I'd really like to encourage as much as possible any members and partners around the board. Anybody who's willing to attend any of our training, we come to facilities and provide training. The oral health strategy action, and we have an oral health strategy group. Any member is welcome to join and tag along to that group. It forms part of our food partnership because of the real strong correlation between food and oral health. Any people working care homes or school governors, drop your child off to an early year setting. We provide all that training free because it's about making every contact count. Those short, sharp messages around, have you brushed your teeth today? Those little prompts, thinking about how much sugar you put in it, have such a big impact on how many children will have a tooth extraction in the next few weeks. Whether a person in a care home setting is having their teeth looked after. So it's really imperative that we train all of our staff. Really quick, simple messages. So anybody who wants access to our training, it's all freely delivered, and we really want to key to that. And then next, we just literally put in the end finishing touches to some campaign work as well, those 3 critical messages. So with permission from Michael, we'll send that around to all members of the committee just so that you can then promote those key messages. So yeah, they're 2 of the kind of biggest steps we're doing over the next quarter.
Thank you, Scott. I'm going to go to Councillor Prenton and Councillor Crozier, and then we're going to finish them with me.
Thank you, Chair. So I want to echo about the new patient premium and the confusion. And just to be clear, if you're using the NHS appointments and the credit, you can't be one of these people that can go from practice to practice. You can do that if you're paying, but you can't if it's NHS. Is that correct? Also, it's disappointing that we don't qualify in Kent and Medway for the mobile dental vans, because they could really alleviate some of the pressure. I know they're designed for rural patients, but they could really alleviate the pressure on our urban population, particularly here in Luton, where we've got high pressure of people not being able to access a dentist. Regarding the dental, again, the golden hello for dentists, has this happened in Medway? Is it something that you've seen has actually happened, and we've got some new dentists coming and the recipient of this golden hello? And referring to the pharmacies, I agree, the pharmacies are really vital to the community, and they're the perfect place for people to get a lot of these services. But the report mentions 52 pharmacies have registered. Are all 52 offering all of those services? Is there a breakdown? Some are only offering some are offering none, they're just registered to offer it. Is there enough infrastructure in those pharmacies to link up with the GPs to be able to advise that they've administered antibiotics, for example? And is there a big communication rollout for patients so that they know that service exists in all these pharmacies? If there is, how's it being rolled out? And then the last point was regarding the health check pilot that is now business as usual. Is this service available across all of the Medway's pharmacies? Thank you.
Thank you. Councillor Printer, who's taking those questions?
The new patient premium, unfortunately, a patient for a dentist can go to any dentist they want. They're not registered with that dentist or only under that dentist for the course of the treatment. So there is nothing to stop a patient going to more than one dentist for different forms of treatment.
Thank you, Louise. Can I just ask, because I got the impression from Caroline that, say, for example, I was a new patient and I went to dentist A for treatment, then I could go to another one, but would I still be able to access this new patient premium from one NHS dentist to another within this 2-year window? Would that be accepted? Would they use up an NHS credit for that as a part of the new patient premium at another dentist?
So that's our understanding of how it will work. In reality, it's probably not going to work like that because getting access to an NHS dentist is hard enough that people don't actually tend to go to lots of practices. But as Louisa said, there is no registration, so patients are free to go wherever they want. The credit that we're talking about is an extra amount of money that the dentist gets paid for seeing that patient. It's supposed to incentivise dentists to want to see patients who've not been to the dentist for a long time, because it's likely that those patients will need more treatment, which will be more costly to the practice. So by giving an extra amount of money, it helps to encourage dentists to see them. But yes, in theory, they can go to one practice and that practice will be paid the new patient premium. If they then visit a different practice for an examination, then that practice will be paid the new patient premium as well.
Councillor Printer, can I just let them come back with the other answers and then come back on that one? Is that okay? Because otherwise it becomes a discussion with all members. So can we just come back with the answers on the...
So in terms of the golden hellos, which was the other one I think you're saying, so I think we put in the paper that we're still waiting for detail in terms of dentistry on how that's going to work and what that will support. We obviously have had an attraction package for GPs, and there has been some benefits, particularly I guess in terms of providing capacity for supervision and also the training and education environment as well that's offered through that. So there's some learning that we've got in terms of how that's worked for general practice, but specifically for the dental one, we're just waiting for further details to come through. In terms of Pharmacy First, because you mentioned about the comms and engagement. So there was a soft launch on the 31st of January where the service went live, and that was predominantly just to make sure the pathways are working effectively, and it kind of embeds itself within the services. Nationally, there is going to be a real big program and a push around promoting Pharmacy First to the public. And again, we'll be linking in through our comms and engagement teams. We're really keen to work with colleagues within the local authority as well to make sure we can get that communication out. And again, make sure people are aware of the services, but also how we can help build confidence and trust in using those services as well. But Mark, did you want to touch on the other points around pharmacy?
Yeah, just to echo what you've just said, Suk, and to say that we started this journey in 2022, around the time when we had this strep situation. And this is when we had what you call GPC PCS, where referral can be sent in community pharmacy. We had over 10,000 referrals into community pharmacy in just 1 month. And what is great about how we've walked it through is the methodical process, an operational process we have in place where we've got a colleague at the primary care ICB and LPC really looking at each referral to ensure that we're closing them quick enough. Because what it is, as colleague mentioned, pharmacists are quite busy, and these referrals go through a system. We need to ensure that those referrals are being picked up quick enough and those patients seen quickly and get access to their healthcare needs. And as a result of the work we've done, that's really paid a lot of dividend with going into Pharmacy First launch. And we actually got nominated for an award by Health Watch for the collaborative work we've done with our general practice colleague, with ICB, to ensure that the process of this referral is absolutely seamless, really. So, and also, as I mentioned, we worked really hard to get all our pharmacies upskilled, because this is a nationally commissioned service. It's what we do locally that is more important. And this is why, although we had to do that on a Sunday, we got our pharmacies out on a Sunday, 120 pharmacies, 60 in the morning, 60 later on in the day, to get them really upskilled in some of those key 7 ailments so they can be confident in treating those patients as they see them. One of the key things we've done is the use of otoscope, which pharmacists are not really familiar with using an otoscope. So we had a medical practitioner come in and really train them on how to use them. And the feedback has been absolutely brilliant. And as I mentioned, we haven't had any issues as a result of the fact that we upskilled them at the onset. And there are massive campaigns happening across the board to try and educate our patients to continue to access their pharmacy with regards to this service. What is great about the 7 common ailments is that, as I mentioned previously, we keep referring people back to different systems. We can't really do much with those particular ailments. With this particular ailments, these are people we see every single time. We see sore throat all the time. We see coughs all the time. But if there is a sign of tonsillitis with silent infection, we can't do much about it. We know what to do, or infected insect bite. We know what to do, but we can't really treat those patients. And our general practice colleagues were not very happy that we're referring people back, but we have to refer them back. So this particular initiative is really a great news story for residents that live in our communities, and us as a healthcare professional. We can be able to utilize the skill that we've gained over the years to be able to really treat people out in the community.
There's a final question around health check pilot uptake. So not all pharmacists do the health checks. We haven't deemed it appropriate from all in terms of practicality staffing. We initially signed up 7, so we wanted to have all primary care networks to have a fair geographical spread. And what we've looked at within that primary care network is there a particular practice that has no uptake or low uptake for the health checks because of their own staffing levels? One primary care network area just had a staff leave, so we're just looking to recover that. So there will be the intention to have 7 continue during that pilot, and then if that continues to grow, maybe 2 as we go through.
Thank you, Scott. Thank you, Councillor Prenter. James has got something to add on as well.
Just extremely briefly, and to provide assurance to members around the sexual health and the contraceptive side, those services are commissioned by Public Health. We've got a dedicated service, and members feel free to make an appointment to go down and visit it down at Clover Street. So when we're hearing about gaps that might well be there in terms of some of those services, we have got provision for people to access contraceptive services in other ways. So I just wanted to make sure that we're understanding that we have got coverage.
Thank you, James. Councillor Prenter, anything else about
Yeah,
the
just to say thank you very much. I'm reassured about the pharmacies. I think, as Councillor Brake alluded earlier, it will help alleviate pressure on our GPs, which we know are struggling with the pressure at the moment for lack of numbers. Do you have... you're going to tell me off now, Chair. It was just to say, is there sort of a target date when you think everything will be up and running? People will have been communicated. Is it, you say it's going to be a government rollout of comms. When will that be? That's it. Sorry, at the end.
That has already started. And I'm pleased to say we've got 308 pharmacies now across Kent and Medway. I'm going to batch them up together. And we've got 304 signed up to the service. So the spread is pretty good. It's pretty good. But yeah, the national campaign is already out there. We've got campaign targeted to our general practice colleagues. So in some surgeries, you probably see a poster, 7 ailments, go to your pharmacy. So it's targeted all around, and that campaign has started. As Suk mentioned, it was a sort of a soft launch to ensure that everyone has got all the equipment they need to be able to carry out this the full 7 common elements. And by the 1st of April, every single pharmacy should have purchased the otoscope, because otoscope is the tricky bit of the whole 7 common elements. So from the 1st of April, anybody that haven't purchased or started providing the ear-checked part of the ailment will not be able to provide the service. So I would say the answer to your question, by the 1st of April, everybody signed up to the service need to be providing the full 7 common ailments.
Thank you very much, Mark. Thank you, Councillor Printer. Finally, Councillor Crozier.
Yeah, thank you, Chair, and can I thank you for the report? I thought it was very good. It's good to see that the services are being rolled out in Medway and across the country and taking the pressure off of GPs. Can I just like to, I got the inference within the report that there was, going back to dentistry, that there was an implication that there were more adults being treated than children. And it just begs the question, is there a financial incentive for dentists to treat adults because of perhaps the add-on treatment after their initial consultation, and therefore a disincentive to treat children? They get the same for each. Are there less children being treated than adults? I guess is the question, and why?
I don't know if we've actually got data on that.
No.
But there's no disincentive. No. There's the only... It's not a disincentive, but it's not possible for practices to only treat children, for example, because that doesn't provide funding into the system, because the patient charge revenue, so adults pay for their NHS courses of treatment, provides patient charge revenue, which helps to fund NHS dentistry. If we only see children who don't pay, then nationally there's not enough funding, but there's no disincentive for an individual dentist to not see children.
Isn't that a disincentive in itself?
Councillor Crozier, just press the microphone now. Mark, can you just turn your microphone off, please?
Yes, so isn't that a disincentive in itself, that there is no specific charge for children, that it's more profitable for a dentist to treat adults? Because the dentist that I go to actively courts me to go, and it's ringing up for me to go and have my checkups and see what.
It's not more profitable to treat an adult. So if you see an adult or you see a child, as a dentist, you get paid the same amount of money.
But if you only treat children, you don't get as much money as you do as you.
No, the system doesn't get as much money. So in terms of the revenue from patients paying, it's like a tax.
Yeah.
When you pay your dental charges, that goes into the pot to fund dentistry nationally. And that's the reason why we can't just say we're going to stop seeing adults and we're just going to see children, for example, because we need that money coming in.
Because you said your practice just treats children.
It doesn't just treat children, but we always accept children.
Okay, fine.
Thank you, Councillor Crozier. So, thank you very much for, you're going to get a couple from me now, I think, but thank you very much for the honest answers and the report and the briefing. I think, Mark, for me, for pharmacy, I've spoke to a few pharmacists. I'm concerned about that, about pharmacies trying to get drugs. It's really difficult for them to source drugs, especially since COVID. And many pharmacists tell me, and hopefully you will agree, and I'm going to ask you why, that they really get frustrated. One, they're having trouble sourcing the drugs. Secondly, they're not getting them at the cost, which the NHS, the cost. So that causes pharmacies to struggle. But then obviously there's issues with communicating with GPs that still issuing the drugs, but you don't have them. So is there a solution between yourself, the ICB, and that with regards to this? Because it is a big problem. It shouldn't be hidden, because that, Councillor Brake said it earlier, the sourcing of the drugs is a big issue for a majority of pharmacies now, especially the cost. But it is that communication tool with GPs is why are they still prescribing the drug when you can't get hold of it?
Thank you. We are really handicapped, and that's the best way to describe how we feel about this. What we're expected to do as pharmacists is to channel that conversation nationally, and then a conversation or negotiation will happen with Department of Health and Social Care, as to what the actual cost would be, and then that filters down. So it is a very difficult position for us to be in because contractors are dispensing at a loss. We had, a lot of our colleagues, pharmacies close because it's no longer profitable or viable for them to carry on operating in that sort of fashion. And what is also good, because there's always two sides to a coin, is that some of the independents have picked up some of the, contracts. So you've got more, local, vested pharmacies on the ground trying to make a difference. But what we're currently doing locally is to continue to work with general practice, and we do let them know what is available, really, so they can try and find an alternative for a patient. The ICB has an important role, and they do continue to play an important role by looking at the national cascade of information. So where there are issues with medication or drugs, they then cascade that information and bring all of us around the table to trash it out. How do we then move forward? But, it is a widespread problem, and there's no solution, I'm afraid. And a lot of my pharmacy colleagues are really, I can tell you enough how frustrated we are. Dismissing at a loss is not what we want to be doing.
And I thank you for that, Mark, because obviously that wasn't in the report. I mean, there is a major issue with the sourcing of the drugs. There is a major issue. And there are patients going, searching these drugs out, going from pillar to post. Patients that are quite ill and they can't find the drug. And this is happening in Medway. And it's not in the report today. So I think, Mark was really good about thrashing it out around the table. And you are right, Mark, pharmacists are in despair, many of them, with regards to this, because they're having to tell the patient they haven't got the drug. And there's no alternative to some of them either, or at high cost. And these pharmacies need to survive. They're a business. So from your point of view, you've got patients that are going from pillar to post to try and find a critical drug that they can't get hold of, and nor can the pharmacists. What do you do?
I mean, it's a challenging situation. There's obviously, so within the organisation, our medicines optimisation team are the ones that lead on making me getting that message out. I think there is something obviously around communication. It is that part of that. And I think what Mark also mentioned, and you kind of alluded to it, it's almost like you don't want GPs prescribing and then patients going to a pharmacy to find there's no drug there. So actually quite often what we're trying to do at the moment is just strengthen that relationship. So when we got that, we know actually we can just put a message out and say, actually, there's a shortage of this drug. And actually, these are the alternatives in terms of what you can prescribe. And we don't, I mean, none of us want patients having to just try and chase around and find a drug. And I think I've experienced it as a patient looking for something for my child. And it's a difficult process for someone to go through. So anything that we can do in terms of communication channels and everything else just to explain where there are shortages, I think is key. But like we said, it's a broader issue that we've got.
Certainly an issue that needs to go up the ladder more, doesn't it? Because if you've got patients that can't get their vital drugs, it's a bad, and it's not just Medway, it's across the board. Let me move on to dentistry just briefly, because the members' questions were really spot on tonight from all sides, and I think many of them still with a premium out, still no clearer. And Caroline, it was good where you're trying to explain it, because it is a difficult process, I understand. And can I first say, before I go on about the dentistry, I do thank dentists for the work they do. But it is sad, as Councillor Prentice said, there are, and I will go on about those teenagers or those coming into adulthood that are waiting 4 to 6 months to go and have their sedation, to have a tooth out. 4 to 6 months. Wait. To go and have to go and have your sedation because with anxiety they have to go up to East Grinstead or wherever they're going. It's not good enough, is it really? And I think for me, the waiting list is the big issue here tonight, because the two issues for me and other members are we haven't got no numbers on waiting lists, and you're going to tell me there's a whole a reason behind that, and we have got some of that tonight, but. I want to say surely it's not rocket science, because all of these dentists are being handed out these contracts, so that they're being handed out contracts to use, although a majority of them are handing them back, aren't they? So we've got dentists across the whole of Medway terminating contracts. They're handing them back. You put the numbers in there yourself. you know, Gillingham 6,000 UDAs, Stroud 12,000, you know, I mean, they're handing back. So there is a big issue. There is a big issue in the dentistry, but the big issue for your resident in Medway is the waiting list, or them not being able to see an NHS dentist. And we just had it in Faversham, didn't we, just recently, where they queued for 2 days around the block to try and register for an NHS dentist. I just don't understand, for the benefit of our residents here in Medway, I really, and you know, it would be good to try and, for someone to try and help us here, although I've got visitors waiting in the audience that I know that they know I'm very good at time, so I don't want to be, we've already gone over time here. But I really am frustrated that we haven't got that figure today. That I call you here, part of a dentistry service, and no one can tell me out of the 30 dentists or whatever we've got in Medway, no one can tell me how many of those are accepting NHS patients or how many are not. No one knows. But I could ring 10 dentists tomorrow and they'll tell me, no, sorry, I could do that, but we haven't got that detail today. I find that really, really disappointing for it. We won't get a resolution for our residents, even if you tell me that none of them, because probably the answer is none of them are accepting adult patients in Medway. That would probably be the answer. And probably that's what all members here know that's the answer. But for me, you know, sometimes you need a starting point of where we then go after that. Because it's just, you know, it's just not good enough when people are using them. And we have heard some of the stories about people using all different tools to try and deal with their own issues at home. And Caroline, I don't want you to tell us some of the horror stories because you probably know. But, you know, we have to do better, don't we? With regards to it. Surely as a commissioning body, you want to do better by knowing what that figure is out there and what the problem is out there, surely.
So I think just to go back, I guess, if we're looking at how many dentists are accepting NHS patients, we can do that, because that's a piece of work that we can do. It was the waiting list about actually how many patients are waiting for an NHS dentist, which was the bigger challenge. But if you want to know about numbers, we can provide that, and we'll provide that to you. So just to say that that's definitely something we can do.
Okay, and am I probably right with saying that then none of them are taking on NHS patients in Medway at this time? At a guess?
I don't think so, but we will come back to you on how many.
I would imagine that not many. I think, just to finish now, because we move on, just a question to the dentist really, I think it's really important to ask you about what's the morale like at the moment in the service. You know, when it comes to the NHS contracts, I know it was touched on briefly by other members, but so many are terminating their contracts. And maybe they're not getting enough money, and you know, you always get the criticism, don't you? People say, well, they're going into the cosmetic stuff, they're getting more money elsewhere. But I know many dentists that want to do what's best for their residents and their community. So there's a reason, isn't there, that they're terminating, and there's a reason that the morale is so low. I don't know if you want to comment on that.
Yeah, I mean, you don't need me to comment because you picked it up. Morale is very low amongst the dental profession because we've had years of hoping for change and progress is glacially slow, and it's a very hard system to work in. But you're absolutely right, the vast majority of dentists out there want to do the best for people. It's why we go into it. It's what we exist for, and we're trying our best. The ICB are trying their best to work within the constraints that they have to provide the best service that we can, but it's hard. And so, unfortunately, some dentists are choosing to leave for different opportunities.
Thank you very much. Thank you so much again. And you know, Scott, I suppose we are thankful of some of the other opportunities that we do have, especially from the children upwards, with regards to some of the schemes we're doing to educate residents that can't get into a dentist. But it's a very sad, sad situation. But thank you very much for your honesty tonight, and we'll see you again. I know I'm going to pass over to the Vice Chair.
Thank you, Chair. I move that we note the report, and we have Michael, who is going to detail the items that for when you return we'd like to see in your report when you come back, which included the information of what the dental committee is doing locally to help onboard newly qualified dentists and speed up that process, as well as the number of dentists in the area that are taking NHS patients, plus the other items that were highlighted. Thank you.
Is that seconded? Seconded, thank you. All agreed? Is that agreed by members? So Michael has definitely got a note of all the actions and all the things that we said, but we're looking at an August return back on that. So thank you very much. Thank you very much for your time tonight. Thank you. Thank you, everyone. Okay, next item is the Medway Community Healthcare, MCH. Welcome, Martin and Donna. Welcome. Sorry for the wait. I think members know you because they had the training session not too long ago. So straight over to you for your presentation. If you can introduce yourself, might be one or two members that don't know you. So let's just introduce yourself anyway.
No, thank you. Good evening. I'm Martin Riley, the Managing Director for MCH.
And I'm Donna Rao, Director of Transformation for MCH.
And I'm going to hand straight over to Donna, who's just going to take us through some of the main points from the paper. There's 4 or 5 areas I'd just like to draw attention to, and then open it up.
Thank you. So a comprehensive report has been submitted, given the current position of the community health services provision. I just wanted to point out that Medway Community Healthcare is commissioned for the delivery of community healthcare services in Medway and the wider Kent area, and that includes emergency dental provision for out-of-hours, weekends and bank holidays. Looking at the current performance of adult services, I'm not going to go through it all. There were 4 key areas that I pointed out within the paper and the actions that we're taking to address some of the longer waits for those services. And that includes the recruitment that we've undergone, some of the transformation of services and also training that we have undertaken. So focusing on MEDOC, just wanted to set out that there's actually 2 aspects to the provision of MEDOC or Medway on-call care. There's the urgent treatment centre and then there's the GP out of hours. The urgent treatment centre or ED walk-in patients, that is subject to the Type 3 performance, the national 4-hour target. We receive 111 calls via direct access bookings, receive CCAM patient conveyance direct to MEDOC, and during peak demands in ED, our MEDOC clinicians actually attend ED to support and redirect patients, even going on to the back of ambulances to do the assessments as well to support as a system. And we also provide the primary care support for the urgent community response. Our GP out of hours service is provided from 6:30 in the evening through to 8 o'clock in the morning, and that's Monday to Friday, 24/7, weekends and bank holidays. And likewise, we receive 111 calls via direct access bookings, provide 24/7 clinical service for patients who suspect of DVTs and cellulitis. We also do home visits, provide telephone advice to paramedics and CCAM in and out of hours to support signposting, as well as providing GP protected learning time cover so that they can have the necessary training they need. We also provide the hospice palliative care hotline out of hours, as well as supporting on any kind of influenza A outbreaks in communal settings. So our urgent treatment centre activity levels, they've been consistently high since May 2023, with activity levels beyond the contracted activity levels. As you can see from our Type 3 performance, in September 2020 as an emergency system, we actually launched direct access booking, which is known as DAB 111. We were really proud to have won the Medway and Swale Health and Care Partnership Health Service Journal Partnership Award for that. But with the introduction of DAB 111, it was expected that this would reduce the footfall into ED due to the change in patients' behaviours by phoning 111 first, rather than attend an ED. But despite putting that in place, there's been an increase in the number of 111 calls to the UTC, but there's been no decrease in the number of ED attends. And whilst MCH commissioned to see 145 patients a day, as I say, we're actually generally seeing much higher levels than commissioned. There was recently concern raised about the non-achievement of type 3 performance as a system. However, on review of the causes of the breaches of the target, it's been observed that over 50% of the breaches are contributed by patients taking in excess of 30 minutes to walk from ED into a co-located urgent treatment centre, as well as a number of patients already having breached the 4-hour target before actually arriving in Medoc. So I thought, just to give some perspective on this, we've done 2 sample days of looking at the breaches. As you can see, one day, 57 breaches in total, with 2 patients taking over 3 hours to walk next door. And a similar finding when we had 72 breaches, 4 patients taking over 3 hours to arrive in our department. So to add to that, we've also got the issue that our patients are generally, the acuity or the complexity is increased, and therefore we've had to increase our consultations from 20 minutes to 35, which of course is affecting the capacity. And also, 1 in 5 patients that are streamlined from ED into Medoc are then being assessed and then requiring inpatient transfer. And that takes time to get that patient agreed, handed over to the inpatient services, and all the time the clock is ticking through. I've already mentioned that Medoc support the urgent community response. So I thought it'd be helpful for you to see the kinds of services that urgent community response is supporting. It is 7 days a week, it's a 12-hour service, and the main focus is the admission avoidance as a primary function. Referrals are continuing to increase month on month, and as you can see, we get a range of referrals from GPs, other clinical health professionals. Whilst we have not achieved the 85% target, we actually have seen since April 2023, 7,734 patients, and of those, all of them have avoided the need for acute admission due to the urgent community response intervention, which is phenomenal for those patients. And as you can see, 93% avoided admissions due to the 2-hour response, 94% due to the 48-hour response. We are actively recruiting more staff. In fact, we've got interviews next week to continue to increase activity levels and improve access and waiting times for patients. Moving on to discharge, obviously, as we know, currently MFT are reporting higher levels of patients remaining in the hospital where clinicians have identified they've got no criteria to reside. This is a significant concern both for the patients currently in the acute and for patients needing to be admitted. So therefore, hospital discharge is a high priority for all system partners within Medway and Swale. So to support that, we requested jointly an independent audit, which was undertaken by MCAP, which is an external organisation, to explore as system partners how we could look at improving discharge processes. And any improvements we would actively take responsibility for looking at and addressing. So I've given details of an overview of the audit outcome, but I'd like to draw to your attention that of the 490 patients, it was noted that 38% of the patients could have had their care provided in an alternate location, which means 62% of the patients were delayed due to internal reasons, including delays in the medication for the patient to take home, patient transport, appropriate discharge documentation, and no weekend reviews. So despite the challenges that we've had, we've still continued with a lot of transformational change, which I wanted to highlight. So firstly is digital first approach. So MCH, we're looking at innovative ways to interact with our patients to improve access and move towards a digital front door to the community services. We're looking at introducing a patient portal that will help patients in having digital access to their patient journey. So it's not just about their initial appointment, it's they could have access to their appointments, patient literature, videos, all of the workup prior to attending their appointment. And we see that as a really positive way forward. It also allows patients to communicate via two-way texting with our clinical service as well as supporting self-referrals. And we've rolled out self-referrals over the last 6 months to a number of services to support patients with patient activation and empowering them. Obviously, there's the flip side of that not all patients are digitally enabled. And we're cognizant of that with any of the transformation work that we're doing. And therefore, we will always have our single point of access, so patients can have a traditional phone and a traditional telephone call with somebody to talk about their appointments. And that's through our central point of access or our care coordination centre. The other transformational change, which is a big piece of work, is we're actively reviewing our structure and looking at future form with the emerging health and care vision around integrated neighbourhood teams. So in line with the vision of integrated neighbourhood teams, we're building on the success of collaborative working with primary care that we've already been doing for the last couple of years, and adopting a self-empowered and integrated team approach. That's not just our service working integrated, it's working with Pharmacy First, with our GPs, with other services that are within Kent and Medway. And the whole reason of driving this is not only about self-empowering teams, it's about giving patients better outcomes, addressing the population health needs, reducing clinical variation, with the whole focus to having patient-centred or person-centred care out of hospital, with the aims of reducing admissions, providing earlier safe discharge, providing in-reach care to have continuity and outcomes, as well as organising a joined-up approach to address individuals' social and health needs. And once we've organised the teams into those areas, then that enables wide-scale transformation, which we can then drive efficiencies, enhanced ways of working, and achieving health improvements, and reducing some of the transactions or frustrations of not having integrated, joined-up approach at the moment. As you can see from the illustration, we're planning an approach based on 5 locations rather than PCN level, because some of our PCNs have practices across Medway rather than a specific geographical area. So, as I say, large transformation programs will be enabled through those neighbourhood teams, working collectively to deliver change and reshape clinical pathways. And co-design with our patients and other services is absolutely essential to be able to do that transformation change. One of the things that we've put in place over the past 2 years is actually the Medway and Swale Health Hub. As you're aware, there are a reduced number of GPs in Medway and Swale compared to either nationally or Kent and Medway, so we knew that we had to do a different model to improve GP access for our patients. So with some funding, initial funding from the ICB, we developed the Health Hub, which is clinically driven, and we see online consultations for 2 PCNs to improve access for patients. Following the initial pilot, we had to pause just for a short while whilst we worked with our primary care clinical directors, because it was such a success. We wanted to prove and continue to roll it up and scale it up, and it is a scalable service. We've worked with our primary care clinicians, and as a result, we were able to turn it back on in November, which was perfect timing as well to support winter pressures and patients accessing those GP services. As you can see, we've had some really good positive outcomes for our patients managing online consultations, with 100% of those patients referred in being triaged on the day, 100%. with 80% of patients being discharged on the day with their treatment, with very minimal patients being required to escalate to ED or emergency care. We're working collectively with clinical directors to fully embrace the recently launched Pharmacy First. In fact, I was with the GP and a pharmacy only today to look at how we can work collaboratively, improve pathways and support the whole programme. And that was a really positive, and all of us agreed that actually that monthly meeting to be able to drive that better access for patients was vital. Next steps for the Health Hub is the continued expansion. That would be the plan. To provide services to underpin that INT central hub approach, which again is part of the fuller stock take, is to have that hub approach and non-silo working. NHS England primary care team has shown significant interest in our Health Hub model, which is really positive for our patients and for the clinicians providing that care. And recently submitted a case study for a Health Hub, and I had the first draft this week, and it looks fantastic, and I can't wait for that to be published. The one thing about the Health Hub is the need for substantive ongoing funding to support GP access.
Donna, is there a slide, sorry, is there sort of high, because most of the members have read the report, so just to help you along, they have read most of the details.
So the only other point I was going to touch on was the urgent treatment centre provision. So as described earlier, there's two aspects to it. MCH and MFT are jointly working on developing a model which will separate the functions, with the UTC element becoming integrated within the ED service operated by MFT. The ICB have recognised that there are a range of different models for the UTC across Kent and Medway, and to that effect, MCH have recently been notified that the ICB wishes to carry out a procurement for the UTC. We're currently working with the ICB as this may cause a delay in implementing the shared model that MFT and MCH have developed.
Thank you, Donna. Mike, is there anything you want to add, or do you want to wait for questions from members?
I'm happy to wait for questions.
Thank you very much, Mike. Thank you, Donna. Councillor Joy.
Thank you, Chair. Just a question on cardiology 4.1.3 on page 38. It notes that you've had increase of a number of referrals for cardiology diagnostics, and you've taken on two additional nurses. I'm just wondering, with the recent launch of the NHS campaign around cardiovascular disease, the likelihood of referrals is going to increase even further, mainly targeted people over 40, try and, in the first instance, get their blood pressure checked, which would potentially lead to highlighting and identifying a lot more people with cardiovascular disease. Do you feel that with them increased numbers that you've got the capacity to take a lot more referrals coming your way?
It's a really good question, thank you. So CVD is actually one of the first transformation programs we want to focus on through the INTs, because it isn't just about how we deliver the service, it's about collectively how do we deliver to improve cardiovascular outcomes for patients. So that is one of the key big pieces of work that we want to do. Whether we've got enough staff, I think there is an opportunity working with primary care, looking at the ours funding, for example. That becomes an opportunity where allied health professionals can be brought in to support that pathway, but it is through that co-design, as I say, and actually understanding the needs at the locality level that we can then do that balanced approach.
Thank you. Councillor Mark Printer.
Thank you. Just focusing on the part on pay awards. Disappointing to see that you didn't get your funding from either the NHS or from central government to cover that. However, I'm pleased that you honoured the pay deal, because I believe that's important for your recruitment and retention, and that we're not doing a race to the bottom on wages for our medical staff, which is important. However, on that, I noticed you've gone to judicial review. Is there any news or on a date when that will come back? And also, 2.5 million is a lot of money. Is there a pressure on providing the services now you've got that 2.5 million black hole in your budget? And will you be budgeting for potential higher pay rises going forward now this has happened? Thank you.
Thank you. So where we are with the JR, we've paused it. So there's a number of social enterprises across the country, all in the same position. Not all awarded the pay award, so there was a mixed sort of bag of those. We felt it was important for the reasons you outlined in terms of the staff are working hard. They're the same, they represent the NHS on every level, they see no differentiation of that, so, and we're on the National Pay Award as well, so they're on the same gradings as neighbours. So again, if you don't pay that, then quite easily they can move across. So the 2.5 was significant. We took a loan out to use that. Where we are with the JR, that's paused because centrally the Treasury has said that they will start to fund it if we met some criteria. There was 3 criteria of the test that we had to apply through. We successfully met those criteria, submitted that in January, and we're still waiting. So only this week there's calls weekly, as you can imagine, on this to whether we continue then with the, where we are with the process. We're still optimistic. Regardless of that, we are budgeting for the pay award because, again, Gender for Change is a national scheme, so we're part of that. We've never moved away from that, although being a social enterprise. So we have to budget for that pay award for in future years. So it does put a different cost pressure on as a community interest company.
No, just to reiterate, I'm glad you're still staying within the national pay bargaining moving forward, and you haven't taken the stance that some other community interests have taken. Thank you.
Thank you, Councillor Prender. Councillor Brake.
Thank you, Chairman. Thank you very much for the additional information that's been provided this evening. It's always very useful. I've just got 2 points, if I may, please. One is a direct question, and I notice on the, what is it? It's tissues and wound care. But this is obviously a very useful and very worthwhile piece of work that is undertaken on behalf of the GP surgeries across Medway. And following on from that, I was pleased to note that dermatology is now being picked up by MCH, and I think the service is being provided out of the Raynham Healthcare facility. Can you confirm that that is a permanent feature, or is it just something that's come in and will disappear? The reason for me asking this question is that, of course, dermatology was a service that was removed completely from Medway several years back, much to the annoyance of all members, irrespective of which side of the divide they sat. There was no real consultation. It was just removed from Medway, and a lot of people subsequently suffered as a result of that with various skin problems. So I'd like to know if this is something that has been put back in the system, and how did it all happen? That's question one. Perhaps you can deal with that one first, please. Thank you, Martin.
Okay, thank you. It's not MCH providing the dermatology service, but my understanding it has been commissioned, so it should be substantively being provided. So it's a wider piece of work across the whole of Kent and Medway around dermatology services. As you correctly state, there was a point where both community and acute provision stopped, but that's been an ongoing piece of work. So it is, my understanding is it is starting, but I couldn't tell you who the provider is at this moment in time.
Thank you. I think that, and I'm sure all of us would be very interested to find out the ongoing saga, if I can put it that way, of dermatology. It'd be good to know that a service is back here in Medway for the benefit of our community. That was my first point. Second point, if I may, please, I was looking at the breaches where people will go from ED, literally a few yards into the Medway area. 57 breaches on one day and 72 breaches the other day, which is anything between 30 minutes to 3 hours. Is this something that there is an ongoing discussion with MFT over this, or are you just reporting it and saying there is a problem, but we don't know where the issues are and how we're going to deal with it? What is the situation, please?
No, we're working quite closely with MFT. So only today, Jane and I had a further discussion on how we integrate that service further. And it's not just the time taken to walk around, it's the time for triage if they're waiting. So it's waiting in the ED department. Then if they meet the criteria to be streamed around to Medoc, the clock is still ticking. So that's where it's, but we have had cases where patients have chosen to go and get coffee in between coming around as well. So that's where you get some of the long, you know, excess. We've had, 8 hours where people have gone out of the hospital and then come back. So, but in terms of the clinical pathway, that's something we're looking at as a whole system. Obviously, CCAM later are part of that process as well. So I won't steal their glory on their improvements of ambulance handovers, but again, it's the whole process from when the patient first arrives through to when they leave. So we're looking at changing the whole process for that. And again, hopefully that'll be imminent and we can start to convey a different way of providing the service.
Thank you for that, because I think that has clarified an awful lot of, and I'm sure other questions would have been forthcoming, what's gone wrong in the system. But what is happening, in fact, is that people are going, correct me if I'm wrong on my interpretation, is that people are going into ED, and that's the moment the time starts, from the moment they register with ED, and for the time it takes for the triage until eventually it's somebody that is dealt with by MCH services. But as has been pointed out in your report, there are cases where some of those individuals do in fact have to be referred back into the hospital for further treatment, etc., etc.
Thank you, Councillor Brake.
Thank you.
Councillor Nang.
Thank you very much for your comprehensive report. My question relates to the report relating to patients not being discharged due to internal reasons. You did say after the research carried out by MFT, they came up with some data. Now, from that data, what are the plans to ensure that that will be reduced, or what are your plans to make sure that patients that are supposed to be discharged will be discharged on time, so that they will make way for other patients to have access to the services? Because I think most of the staff do complain about that area with patients not leaving the hospital, and also most of the time most of those patients go and the same people come back again within the shortest possible time. So what are your plans towards those areas? Thank you.
So again, with MFT and with members of Medway Council, we're looking at a transfer of care hub to change the whole flow of discharge. So how we pull patients out. So once the no criteria to reside, actually, we know that a patient laying down in the bed, the deconditioning, we need to put them in the appropriate place. So some of the models we're looking at is having step-up beds. Again, looking at alternative pathways. So rather than patients, as it says in the report, a number of patients are being admitted into the hospital that don't need to be there in the first place. So it's how we deal with those and take those to the appropriate setting. Then if they are in the hospital, it's actually how do we then speed up the process that on arrival they're given an estimated discharge date, and then we work around that. So again, there's a number of improvements we're working across. Some of those are in our control, MCH, and how we run some of the services, and some of those are us as partners. But again, it's collectively working together to improve the situation. No one party is going to do this alone. So Leanne, Jane and I now meet weekly on a weekly basis just to go through some of this and look at the models, and we've got to a point now where we've got a new model proposed which we're agreeing to and looking to implement. In terms of some of the failed discharges or the turnaround, again, we're reviewing those. So working with the medical director of MFT, working with some of the primary care clinical directors from the PCNs, we're going through examples to try and have lessons learned about exactly what's happened, why was the patient discharged, what was the appropriate pathway they should have taken. So we're trying to learn that one by one. So it's not hearsay, it's fact. And again, trying to implement change based on those lessons learnt.
Thank you, Councillor Lane. Councillor Hamilton.
Thank you, Chair, and thank you, Donna and Martin. I'm one of the new people, so thank you for introducing yourself. I've got a couple of questions. First of all, like Councillor Prenter, I really want to commend MCH on the approach you've taken to the pay awards. I think it's brave, and I think the fact that you've had to take out a loan of 2.5 million is just not acceptable. But that leads me on to, obviously, having read your report, I can see that you've still got significant pressures around recruitment, and I suspect also retention as well. My first question relates to 6.7, the continuing healthcare end-of-life carers. Could you indicate roughly what percentage of hours have had to be reduced to remain within the block funding? That's the first question. Second question, once I get to it, relates to the Doctors' Pay Award. And what is the reason for the delay in the funding being received for the 0.7 Doctors' Pay Award? Thank you.
Thank you. I don't have the answer of the number of hours, but I can get that information and provide that back for you.
I just think, given that it's such a key and sensitive service, it's really alarming that you've had to reduce the hours around it.
Absolutely. That's how we feel from a clinical point of view.
So we can add that. We can definitely add that one for a briefing note, if that's okay with you. That be okay?
Yeah, we can provide that. In terms of the pay award, it's part of the overall discussion and negotiation for contracts going forward. So it's part of the financial balance across the wider system. So hopefully that would work itself out in the next few weeks. But again, it's an example with, as a community interest company, there's a difference between being an NHS trust and a CIC. And there's access to some of these funding routes that does have an impact.
Can I just come back on that? Obviously, as a CIC, it's really important that you're maintaining competitive benefits, packages, wages. So it's really concerning that you're in this position, from my perspective. And clearly that's also going to make it very difficult for you to attract really good, high caliber staff who are going to stay with you. So I just would like that on the record. Thanks.
Thanks, Councillor Hamilton. Just finally, Councillor Crozier.
Thank you, Chair, and thank you for the report. And I was one of those that came to it was a very, very good day. I thought that was great. Can I just look at page 47, 5.12, the little scenario you've got there with the 100% of people were triaged on the day of receipt, and I think that's kind of about the e-consult system, isn't it? Can you give me an idea of the cohort of that study, and perhaps just dive in a little bit to the 80%? Because it seems that 80% of the people that you discharged on the day, were they just like waste of time calls, and then there's 20% went on to...
Sorry,
how successful is e-consult? Is basically what I'm asking.
Yeah, so e-consult is very successful. Yeah. We've had, during a 9-month period, we had over 20,000 online consultations. Wow. Patients have loved it. We've had very good feedback from the patients. Great. And they've been happy to recommend on to friends and family as well. And that's why it's proven to be so successful. It's also been successful from a point of view of primary care with regards to when patients phone through to reception, the appointments have gone for the day, they've now got an alternative, and that's the online consultation. That has been a breath of fresh air, not only for the reception staff within surgeries to say, actually there is another option, but also being able to provide the care when they need it. The 80% of patients that are discharged on the day, they are going away with treatments, referrals into secondary care, referrals into community services. They're being completely managed. The 20% where we can't do that on the day is a mix of they've got a long-term condition, so need a follow-up in 3-6 months, for example, or they need a physical hands-on assessment, and for clinical appropriateness, we ask for a face-to-face appointment. And we have carved out appointments with our GP surgeries so that that immediate access can happen. So they've been seen, they've been triaged, we know they need to be seen, so they're booked in for the day.
And what reaction are you getting from GPs about, the success of that?
They've loved it, and that's why we've had the support from the primary care clinicians with helping us fund and be able to reopen. And, a number of GPs sit with me and say, this has to be the way forward. It's such a huge support for them.
And with that, have you got any information around people my age and older that are trying to access the system? How are they getting on with it?
So we have patients from babies. Our eldest one is 101 years old. So this is open to everybody.
Yeah. Thank you very much.
Thanks, Councillor.
Thank you, Chair.
I'm going to have two more members. I've already got Councillor Campbell and Councillor Printer. If it's a quick one, Councillor, I may let you, but we'll see how we get on. But just can we have direct questions, please?
So just looking at the report, I get the sense that there's a lot of innovations that you're trying to implement. There's a lot of efficiencies you're trying to implement. You're trying to work really closely with partners and stakeholders to try and kind of fine-tune some of the processes. It seems to me there's a lot of stuff you're waiting on the ICB to progress. Maybe a sensitive question to ask, but if you had a magic wand, if you had one ask of the ICB, what would you ask for that would just make all these blocks go away? If there was one thing you could change about it, what would that be?
Clarity. I think some of the, everyone's trying to, so as a system they're trying to improve, trying to redesign. I think it's just ensuring that what can be locally driven and locally determined. So working as a local system, there's a number of things that we can probably just move on and go quite quick with. And I think it's just some have impact on other parts of the system, so we need to be cognizant of that, but some we can just do. So there's a number of those initiatives that outlined in the paper that are just trying to move on. And some of those are MCH alone, but some of those, it's hard to do these alone because it's usually as a system with partners you need to do these. And I think as a local system we're working quite well together. So it is just some clarity on one or two parts.
Thank you, Councillor Campbell. Councillor Brinter.
Yeah, two quick questions, really. You referred, Donna, to the option for non-digital interaction for patients, which is, as we know, not everyone's digital. It's not clear on the continence service, the self-referrals there, is that the same? Can people pick up a phone to self-refer for that? That's the first one. The second one is, it's good that you've got a new recruit to the diabetes team. What can you do to reduce the number of patients that are not turning up for appointments and effectively wasting time? Thanks.
Thank you. So to answer the question around the non-digital impacts on that, self-referrals. So self-referrals is excellent for people that have got the computers. However, what we've done is we've actually trained our care coordination centre to actually ask the patients those same questions. So we still get the clinical information that we need from the patients through those structured questions. And then that enables the clinicians to then respond, so reach out and ask them to do X, Y, Z ahead of their appointments. But that's the kind of thing that, we still provide the telephone call. We've trained our admin staff to be able to do that. And then your second question was, sorry?
The wasted appointments for the diabetes.
Yeah. So that's the patient portal. That will be the biggest support. So where other providers have rolled out a patient portal, the reduction in DNAs is just really high. And we recently rolled out text in first to patients for our nutrition and dietetic service. They were also struggling with very high rates of DNAs. By doing the text ahead of us phoning within 48, 72 hours, the DNA rate dropped significantly and has been really, really successful, which means obviously better clinic utilisation, more patients being seen.
Thank you, Donna. Councillor Cook.
Oh, thank you, Chair. I appreciate it. It was just to follow up on something that Councillor Crozier asked. Conscious 5.9, lower levels of GPs per 100,000 in Medway and Swale in comparison, and so the Health Hub has responded to that. So can you just clarify, what proportion of kind of surgeries in Medway were involved in the pilot, and how easy will it be to roll that up? Is there, obviously we can't compel GPs to take this on, so how likely are we to be able to scale that out across Medway? Thank you, Chair.
Thank you. So as part of the proof of concept, it was open up to 7 practices across 2 PCNs, and we got full utilisation. Some GPs were only open for a short period of time, so the benefits for some surgeries was a 400% increase on online consultations being available to patients. With regards to scaling up, as I say, it is a scalable service. However, it's sustainable funding that makes the difference. We're very fortunate that the CDs that have come forward to support us with being able to open, again, that's across 2 PCNs, one of them being one of the ones that was in the proof of concept because they realised the benefits of it straight away when it was stopped. We've had people wanting to come forward. We've had GPs that want to do this. It would be a way of recruiting and retaining some of the GPs and having a hybrid model as well.
We are meeting with all of the clinical directors from the PCNs in 23rd of April, I think it is, so to go through this model and to look at how we can scale it up.
Thank you, Councillor Cook. Thank you so much, Donna and Martin. First of all, I've just got 2 questions. First of all, I want to reiterate again of how informative it was when we all come to that. You was the first one of many different training things we're going to be doing with partners, so you set the bar quite high there, so well done for that. It was really, really interesting. I just want to focus on 2 quick points. The first point is you've made it very clear in the report about the fragility of services and the pay award and the end-of-life care, etc., challenges, I suppose, Martin, you commented a minute ago about this procurement process that's ongoing now and you're involved in. Are you concerned about your services and the fragility of MCH going forward on this process now?
I think it's a concern. I think, I suppose that's where the clarity is. It's being certain of timescales and the impact and sort of what's included, what's excluded. So it's for staff. It goes back to the staff morale part. So our retention is quite good. We do recruit quite well. Our staff survey again was quite positive this year. But earlier this week I went to a team meeting where there's been an unknown sort of procurement hanging over them for the last year or so, and on that day two members of the team were leaving and they cited that as their reason for leaving. Luckily they're staying within MCH, but again, it's the UTC service, which again is under pressure. It's the Medoc service, it's under pressure. So we're struggling, that's a hard area to recruit to. So the uncertainty is where it does become more complex in trying to deal with it. But in terms of the funding across for all service providers is obviously a challenge. I think that's part of the working as a wider partners across the system is how can we get efficiencies, because we know there's duplication as well as across organisations. So actually if you streamline things, can we work differently and can we get those efficiencies out of the system?
Thank you, Martin. I was going to ask you and Donna about the urgent treatment centres. Unfortunately for us, we only found out about the procurement of the urgent treatment centres yesterday. And then unfortunately as well, we found out it'd already gone to HOSC a few times, but not to here. So we are dealing with that. We're going to pick that up because obviously it's quite disappointing it didn't come to Medway. And yet again, we only just got the briefing note by accident yesterday. I was going to ask you some questions about it. The final one is just about the next item on the agenda is the TIA service. And I just wanted to ask, without going into too much detail, but obviously your staff, you staffed that TIA service at Medway, and then them staff moved across or moved aside. Was it the ability of not being able to staff it in the future again, or was you not asked to staff it in the future?
I think that was the change in model, looking at the centres of excellence in terms of what it is. What we have been able to do is still keep a group of staff in the community, so as patients are expatriated back, is then can provide that specialist service, and that's still ongoing. So I think that the model's changed nationally, which I'll obviously go through into a minute, but we've still got the service locally around. Actually, once patients are back in Medway, then we look after those patients.
It's just that on all the reports, it was that because of your staff left, they had to change it. I mean, is that the case?
Well, once the decision was made that the specialist service was no longer be here, then staff voted with their feet in terms of their own careers and training, etc. And I think that's the issue that hangs over with all of these decisions.
So thanks, Mike. Thanks for clarifying that. So the staff didn't move, and then the process was put in place. The staff were told the process was changing. That's why they left, which isn't what we've had in all our reports from the TIS service so far. But anyway, thank you very much. Thank you so much for you both for coming, and sorry for it being a late night. Can I ask the next item on the agenda to come? Oh, Vice Chair, sorry.
Thank you. I move that we note the report and we get a briefing note providing data on the number of hours reduced in order to remain within the block funding for end-of-life carers.
Thank you. And I will add for Councillor Brake, we have added about the dermatology, maybe bringing back that. We can invite the dermatology service to come back in, and we'll look at doing that as well to put it on the plan. Okay. Thank you so much. Thank you. Sorry? Is that seconded? Yeah, it's late in the evening. Sorry, seconded. Oh, no, you're going to second it because you're good with this, right? Okay, can we have the next item? What I am going to do, if I can just ask item 8, if I can ask the guys to come forward, and I'm just going to give the members 2 minutes, a 2-minute just quick break to grab a drink, and then we'll be back up. And CCAM as well. Honestly, I will be asking people to keep to time now, so we will be with you in a moment. Would you like to, you're back again, so would you like to both introduce yourself, please?
Hi there, my name's Pete Maskell. I'm a consultant geriatrician and was a stroke consultant in Kent and Medway for 10, 12 years. I stepped down from that and continued to practice as a geriatrician. I did that a couple of years ago, but I've also been medical director of the Community Trust and an Acute Trust, and now I'm medical director of West Kent HCP. I've been, sorry, it's too long. You're not going to get home by 9:10 if I carry on like this, are you? I was asked to chair the Stroke Network, the ISDN, and I started doing that at the turn of the year.
Thank you, Pete. We know you, so don't worry. Obviously, we can take the report as read. You can just comment on that or give us some highlights. I think, first of all, I think what would be key is that you heard my last comment with the last item. And all through the reports, we've had that you had to make the decision to take the service out of the hospital because of the staff had left. And obviously, we just heard that wasn't the case. So, and it isn't, you know, it isn't trying to catch you here. It's just that your previous report said it very clearly. You had to make a decision because the staff were no longer there. And then obviously we've been told by the provider that they were already told that it was changing. That's why the staff didn't want to go with the change. I think we need to address that first for the members, if that's okay with members.
Of course. Apologies. I did hear the question. I didn't quite hear the answer, but you've. I think I know where there might be some confusion. I don't know whether they're still here. As you know, there was a consultation with Stroke that took quite a long time, started many years ago, which was signed off by the Secretary of State, and that was around HASUs. I was working in one of the stroke units that wasn't going to continue being a stroke unit at the time. However, we were waiting quite a long time for all of the legal challenges and the Secretary of State to sign off. In that time, all of the staff who knew that it was likely that the Secretary of State was going to sign this off, they all jumped ship, and so we needed an emergency transfer of stroke care away from Tunbridge Wells Hospital. The same thing happened at Medway. And when all of the other acute stroke services disappear, I can imagine, although I don't know, I can imagine that the other staff in stroke services feel unsupported and want to leave as well. I didn't hear with the answer what their staff knew, but I suspect their staff knew that the HASU was definitely going to move, and then it did move in an emergency transfer, as you guys will know. So I think that's probably where the confusion is.
I think it's something we can always come back on, but I think it was in the reports. It was quite clear that at the time you had to make this move to the sites they're on now, Maidstone, etc., purely because them staff had left. So I suppose for us it wasn't in the report clearly or actually factually correct for the reasons that, you know, it was made very clear to this committee you had to make the move to the other hospitals because you lost your two staff. It wasn't because they already knew that there was things happening, it was because of that. And unfortunately, we heard the difference. I mean, it's not for us to, you know, we're here to talk about whether the TIA service is coming back to Medway tonight. So I think that's the issue. But I think it's something we'll pick up, maybe, or sort we'll pick up, because from a report point of view, I wouldn't like, I'm not saying, but I wouldn't like the committee to have been misled by the information, considering the information we've just heard from MCH. So for me, it's just a bit of a, you know, and whether there is confusion, it's fine, but from us, I don't think it's coming across that way. But would you like to highlight your report tonight?
Thank you very much. I'll take the report as read, of course, and this is the third time I understand that the TIA service has been back talking to you, so I wasn't planning to rehash anything, and in the interests of time, I was going to cut to the chase and say that the recommendation is that the stroke service in a hybrid form where patients in Medway will not have to leave Medway is the plan. The plan is to transfer that service back into Medway in August of this year. The patient survey has been done and appended to the report, which you can read, along with the opportunities to get transport to and from Medway to Maidstone or Down Valley. And I think I'll leave it there.
So Peter, just for clarity, are you saying that the TIA service is coming back in its full form in August to Medway?
So you'll see in the paper, there were two options. The first option was seen not to be safe enough at this time, so option 2 was instituted. I'm very grateful for HASC that you've invited us to speak before I chair the programme board, because a decision will be made there with all of the clinicians, and it would be really good to understand your view before I present it to them. Unless you throw something at me that I can't then then recommend to the programme board, that we do aim for an August transfer back. It will be in a hybrid form. So I'm not saying that consultants or specialist nurses will come to Medway to provide the TIA clinic, but they will, like at other parts in the country and in Kent and Medway, provide a virtual initial consultation where they can see the patients if necessary, and there will be certain clinical situations where you will need to see a patient, but investigations, blood tests and prescriptions will be delivered in and around Medway.
Thanks, Peter. So I'll open up to members, but because obviously our starting point at the other two presentations was that members wanted it coming back to Medway in its previous form, but I get what you're saying. Members, any comments from members? Councillor Printer.
So just some clarity on the hybrid form. If patients aren't digitally enabled to be able to have a virtual consultation, is that where they would have to be transported to Maidstone or Down Valley for a face-to-face consultation? Is that the case?
If they are unable to use a phone, that would be the case.
So it's not face-to-face video calls, it's telephone calls?
It could be either, but if the evidence, the emerging evidence that a telephone call is as good as a face-to-face.
Yeah.
And we're waiting on the Oxford study, as you would have read in the briefing paper, to publish its results on that. But a lot of the time, we use telephones.
Okay, thank you.
Thanks, Councillor Brennan. Councillor Brake.
Thank you, and thank you for the update there. I'm going to ask you actually to be a little bit more specific over the venue that the service will be, because your words, forgive me if I don't quote you exactly word for word, but basically I think you said in and around Medway. We know what in and around Medway means to people not living in Medway, and that's where we see services have been taken out of Medway in the past. They've gone to Down Valley, they've gone to Maidstone, they've gone to all parts of the southeast. And this has all been done in the name of in and around Medway. So I'm going to ask you actually to be very specific when you say, where will these services be located, please?
I'm so sorry for not being clear enough. When it comes to, so there are 2 or 3 areas, I'll be specific, 3 areas where patients need to attend in person, somewhere to get what they need. The first is with radiology. So that's CT scans, MRI scans, Dopplers, and they will be done at MFT. The second is cardiological tests, and they will be done at MFT. The third is with prescriptions, and they will be done at MFT. I've spoken to the medical director of MFT today, who agrees with that and sees no reason why this will not happen by August. The reason there has been a delay is because of a delay in the rollout of the computer program that has meant that up until August it will be unsafe because we will have to rely on paper records. And, you know, I will go as far up to but not giving you my word because IT programs are difficult to implement. And I must be mindful of that, as is the medical director of Medway. I know her well, we work together well, and in our meeting today, she said that there is no reason why it cannot move by August, if not before.
Thanks, Councillor Brake. So, Pete, obviously you're the expert. So you're giving us, you know, I know there's changes all across the country with regards to this, and as Susan, the best way to work forward. Obviously, the committee here have lost units and lost services from Medway, and that was the initial concern, and I'm sure you can understand that. But from what you're saying, and in your recommendation on 4.1, it's clearly saying that this is the safe option to move to, and that would be a good option for the residents of Medway, and they're not losing out. I think that's the main thing, that they will still get that effective service, that fast pathway that we need to make sure that they're looked after. I mean, that's what the committee is here to ensure. Apart from getting the service back in its full form, your recommended option, I think, is the best way forward for this committee. I mean, that's what you're reassuring us. You're giving us your word. You're reassuring us it is the good option to go for.
Absolutely. It will depend on, and I don't think this is an obstacle, but as the diagnostics MFT, that will be an important factor in making sure that the patients of Medway get a service that is comparable to, say, MTW, where the wait for an MRI is 2.2 days. You can read the data yourself. So as long as they perform diagnostically and on the cardiological tests as well as the other places, then they will have a good service and a comparable service.
Thank you, Peter. Okay, no more members here. Vice Chair.
I move that we note the report.
And recommend, we'll go with the recommendation that you've laid out in 4.1. Yeah, that's it. Thank you. Is that? And before I get told off, is that agreed? Agreed, because I missed it on the last one. They're holding me to account. Thank you so much for your time. I'm sorry to keep you waiting this evening, Peter. Thank you. Thank you. We'll deal with that confusion around the report separately from the committee. Thank you very much. Thank you. Thank you, guys. Can I ask CCAM to come up, please? It's the only option. It's the only best option you're going to get, isn't it? Good evening, gentlemen. Hi there. Sorry to keep you waiting. I'm sorry. It's been one of those meetings you come into and you think it's going to be very quick and swift, and then we're still here now. So I do apologise. And would you like to introduce yourself, please, for the members?
Thank you, Chair, and councillors and members. My name's Darryl Devlier. You may know my predecessor, Ray Savage, who used to be the Strategic Partnerships Manager for Kent and Medway. I've taken over from Ray a year ago, so I'm afraid you've got to put up with my scruffy beard for these meetings. I'm the Strategic Partnerships Manager for Kent and Medway for CCAM.
Good afternoon. My name's Matt Webb, Associate Director for Strategy and Partnerships for CCAM. I've seen, I think, a few of you before, paramedic by background. And just to confirm, Ray hasn't gone anywhere. He's moved to Sussex and he's still doing a fantastic job.
Good evening. Lawrence Up. I'm the Operating Unit Manager for Medway, and I think most of you have seen me before. It's my third time now, so getting in the swing of things.
Yeah, welcome, Lawrence and Matthew. I hope Ray didn't warn you about us here, because we are friendly, honestly, although you may not have heard that all evening tonight, but welcome. Obviously, we've read the report. I don't know if there's anything you want to highlight from it before members go to questions. It'd be good for you to highlight some issues.
Yes, just 3 points really to note from the report. I think we need to be upfront from the beginning that you'll be well aware of our CQC report 2 years ago that was pretty dire. There's no point saying anything else from that. But I hope the report that you've read demonstrates that we've made some real efforts to make some improvement. Our improvement journey, our recovery support plan has moved us very positively in a range of areas, from operational performance, 111 and the nines, and also the culture and people piece. So we're now sitting in a much more comfortable position whereby as a trust we're performing quite well nationally, in a much better position than we were a year ago. And locally in Medway, our performance is the best, not just across Kent and Medway, but also across our trust. And that's it in all areas of performance, including hospital handover and staff satisfaction. And my colleague Lawrence can answer questions specifically relating to that area. The second thing I wanted to mention is that obviously nationally all ambulance services have been really challenged, and the system pressures within Kent and Medway that have placed us into Tier 1 status have been really troublesome for all NHS providers and other partners and stakeholders. But those challenges have driven innovations, and you would have seen on the news some of the pilots that we've undertaken in West Kent and East Kent that we're looking to fully evaluate and replicate, hopefully, here within Medway. And that's quite important. NHS England are very happy with some of the work that we've been trialling, and we're certainly one of the best users nationally of some of the virtual services, such as uptake of Directory of Services via Service Finder, which is an app that staff have access to, and things such as referrals into virtual wards, one of the best in the South East region. So again, really making improvements in those areas. And the final point I just wanted to highlight from the report is all of this feeds into our emerging strategy that was only just signed off by the board 4 weeks ago. So it's very new. It's the start of our 5-year journey to improve our patient care and better look after our workforce, and also be better partners. And I think we've shown over the last year that CCAM has historically been a bit of a standalone provider and has not really integrated or collaborated well with our colleagues across the adult health and social care sector. But that has very much changed and has been recognised recently. And my colleague Matt can talk more about the emerging strategy and the direction that we are hoping to move in. So yeah, very happy to take any questions.
Thank you, Darryl. Members, look at Councillor Brake.
Sorry, I didn't realise I was going to be first up, but brilliant. I'm just going to refer really to Appendix C, which refers to the handover from ambulance to hospital, and really to not so much a question, but to congratulate the service on the provision that they provide into MFT, which obviously is very much a part of what we're involved in, because the majority of patients going into the hospital via ambulance would in fact be from the Medway and Swale areas. Because I'm sure you appreciate, but we certainly do, that the people of Swale look at Medway Hospital as being their local hospital in the same way as the people here in Medway. And I'm sure if there were Swale people here this evening, if anybody was to dare to suggest that, well, their nearest hospital is Maidstone, you could in fact finish up with a riot on your hands, simply because they believe very much in MFT, the service it provides and what is available. So I would really, not so much a question, but actually a comment, and that is to congratulate the service on what you're doing for the people of Medway and of Swale in giving the very good service that has been recognised not only here across Medway and Swale, but equally across the country. Thank you, Chairman.
Thank you, Councillor Brake. Councillor Printer?
Yeah, thank you. About staff welfare, I mean, when you've come before, you'd had your staff survey, and it was quite damning. There's lots of bullying, harassment, and I think there was racism as well. I assume, and it's good to see that you've got initiatives like building a kinder CCAM. I assume that is being rolled out and improving things. And just on the body-worn cameras, has that improved? Because it says there's an aim of improving well-being and safety. Is that evidential that has happened? And are they voluntary as well, the cameras? And also, has it decreased complaints against you as well? Because I know the police service of Northern Ireland, when they implemented body-worn cameras, the actual complaints against them actually dramatically fell by half because there was evidence to support or not support. Thank you.
So yeah, I can probably answer that. So in relation to the culture and wider sort of staff welfare piece, we've actually seen year-on-year improvement since the first year I came into post here, and actually Medway was the highest rated area in the entire South East region of CCAM for our staff survey. Significant improvements in compassionate leadership. As I said, all of my team have gone through the Building a Kinder CCAM and First Line Managers course as well. I think it'd be remiss not to note our transition into our new site as well in Gillingham. So we moved in there in, it seems longer now, but it's September. And that's been utterly transformational in terms of welfare facilities, trading facilities, and I think that's reflected in our staff survey. In terms of the body-worn camera piece, so Medway is an outlier in respect of violence and aggression against our crews, and in terms of mental health presentations, and a lot of that's linked to deprivation and the socio-economics of the area. The body-worn cameras have now been rolled out trust-wide. They are still voluntary. I believe they're still technically in their pilot phase. The other thing worth noting that we have different in Medway compared to any other region, any other area CCAM, is the Joint Response Unit, which is our collaboration between Kent Police and ourselves in Medway. So that's a paramedic and a police officer working together on a fast response vehicle. And that provides an element of support to our crews because they can get that support in a much quicker fashion. So that's been transformational and has led to improvements in attrition in Medway. So yeah, lots going on, but still more work to do in terms of the violence and aggression piece.
Councillor Brennan?
Yeah, just more of a comment to end with. It's good that you're moving towards that, but when you got to that point where you're building a kinder CCAM, that it continues to be a moving piece and it's just not we've completed this work, everyone's happier than they were before, we've got good surveys and forget about it, that you continually keep moving that piece and listening to your staff. Thank you.
Thank you. Leanne?
Yeah, thank you. I just wanted to congratulate you really on the safeguarding under point 15. For the last 2 to 3 years, I've challenged quite hard on this, and I'm really pleased to see what you've provided, especially 15.5, because this says to me, while there's still more work to do, CCAM is now a reputable partner in the safeguarding partnership. So just credit where credit's due, really. So thank you.
Thank you, Leanne. I think, Lawrence certainly knows, and so I think Matthew, I mean, not, even when I was here before, poor Ray, you'd think I'd give him a hard time. And actually, I'd give the management a hard time and still turn up with chocolates to the station and stuff during COVID and Christmas. But I will congratulate you, because it was a shocking CQC. Let's be fair, and your staff morale was rock bottom. And we were talking like before COVID here, and there was a lot going on. There was a lot of stuff happening with the culture in the service. I think you've done an amazing job at the hospital. That transfer. The first question I have on that, I'm going to always have but. Do you think because of the speed, and I think it's been acknowledged by the hospital, because of the speed of the transfer rate now, is that the reason we're getting more beds in the corridors? Because obviously there are a lot of beds in corridors. And that's not, your service is not a bad thing bringing them in. I'm not criticising it, but I'm just, when you look at the both working together, the faster you're bringing people in and doing the service, obviously, do you reckon that is causing, Lawrence, do you think that's causing a bit of that?
So the first thing to say is that the improvements seen in the hospital, as much as we'd like to take credit for that, and we have been a part of that, there have been fundamental changes made at MFT in relation to the acute medical model and how they sort of triage patients and move patients through the hospital. Patients in corridors, I think what I'd say is that prior to the changes, what we saw was ambulances queuing outside MFT, and we saw patients waiting for extended periods in the community, and those patients have an undifferentiated risk. We haven't assessed them. We have over the phone, they haven't been seen. What happens now is that those patients are handed over, as you said, in record times. I think it's somewhere in the region of 12 minutes year to date. And they are assessed, have everything, have a full workup, and at the point at which they are more of a known risk, they then move to a different area of the hospital. And during extremis, occasionally that can mean that patients are cared for in areas that, as I'm sure the acute trust would recognise, they'd rather not have to use. And that's been the case over winter. But there are large parts of last year where there was no corridor care going on, and handover was still transformational. And I think what I would say is that it's had a huge impact on our ability to get to patients, our response time reliability within Medway, the amount of time that our crew spend waiting beyond their shift finish times. So it has been utterly transformational, and the relationship between the trusts is the strongest it's been for a long time.
Thanks, Lawrence. I mean, let me just make it clear, I'm not trying to slow down and still bring the people up to the hospital, but members on this committee do know you're averaging around 20 to 30, even to 40 hours in waiting now in the hospital once you're in there. So I was just asking about that sort of overload, whether there was an impact. I will bring Matthew in, and because obviously not many people talk about strategy, and I see you had another executive team change in February. Isn't the first executive team change you've had. So that concerns me a little, although from what you're telling me, it's quite positive. But when you're changing your whole executive, and I think this must be the third or fourth or fifth strategy I think I've heard in our time for those of us on this committee. So how confident are you regarding the delivery of this strategy, and how long will this strategy last before the next one, Matthew?
Good question, Chair. I think what I might do actually is to add one more comment to what Lawrence has said. I think it's personal, and then I'll come on to the strategy. The point around hospital corridor waits is around patient flow. And I think we heard that earlier on this evening, actually. So one of our biggest challenges is we've actually seen a reduction in conveyance because of the good work that the team, and I look to Daryl and Lawrence to my left, have undertaken with the integrated care hubs. We're looking at moving and taking those lessons into the area of Medway. And those hubs are around how do we bring a multidisciplinary team together to intervene those incidents earlier on upstream, so actually we're utilising the most appropriate pathways of care. So essentially, you shift ED conveyance to a place where it becomes the last resort rather than the default is the place we need to move to. So we're working with our community providers and local authority colleagues to look at how can we open up and gain easier access to those pathways so we can continue to reduce the patients that we're taking to ED, but also we need to open up capacity within the community because it's a backdoor issue. We need to get patients out of hospital as quickly as we're bringing patients into hospital. So it is cyclical, and I know we've discussed it before. With regards to the strategy, I think 3 to 5 was perhaps inflated slightly, but we have had a number of strategic changes in recent years. As Daryl and Lawrence have touched on and highlighted, we have been on a journey in the last 18 months. We've had the improvement journey. We shouldn't lose sight of the fact that we had 4 warning notices placed upon the organisation, of which we dropped those warning notices within a period of 9 months, and we moved from inadequate to requires improvement within a 6-month period. So we have been on a good trajectory. We've had some considerable changes to our executive team. Simon Weldon joined us last year as our new Chief Executive, vastly experienced, more so in the acute sector. As you embark on a strategic journey, it's going to come with changes, and that's not a bad thing whatsoever. We have got ongoing efforts as we continue to build and strengthen the leadership team, and we need to look, as we take stock, at the capabilities the organisation needs moving forward. What I would say is we have some interim colleagues that are credible and have significant expertise that have joined us. We're at a point at the moment that we're looking at the organisation and where we need to head, and actually it perhaps wouldn't be appropriate to bring in substantive executive positions whilst we're working with the systems to look at exactly what the model of care and service model is that we need to deliver across the 4 integrated care systems. But we do have robust interim measures in place. And as I say, one of the key things that came out of the diagnostics, phase 1 of our strategy programme, was a clear misalignment between our skill sets and capabilities of our people and of the organisation and the patients that we continue to serve. As an emergency ambulance service, you'd expect that the majority of our activity would be high acuity, time-critical injury and illness. Actually, if you look at clinical outcome, that's 13.2% of the activity that we serve. So we recognise that we need to match capabilities, skill sets and competency from the bottom of the organisation to the top and back down again. And that would include reviewing organisational structures, how we're set up clinically from a service delivery model, and I'm very happy to talk to you, or perhaps come back, because I don't think we've got time, but on the core components of our strategy. But you also, with that, look at executive portfolios as we embark on the 5-year strategic journey. In answer to your second point around confidence in the strategy, this has been a co-design process for the last 6 months, and I think that's what's different. When you look at our improvement journey, you look at strategy development over recent months, we have heard from a significant number of patients. We've been out in the communities listening to actually what our people in our communities want to see from their future ambulance service. We have individually engaged with 2,000 members of our staff. That's not transmitting, that's not communication, that is one-to-one meaningful engagement, and we've been working with our partners on co-design. So we've had a series of ICB and integrated care system workshops, of which I know that some colleagues from local authority have also joined us there. So I guess the point I'm making there is it's a co-design piece, and actually we have a collective responsibility, both from a CCAM standpoint and across the systems, to deliver the right model of care within that integrated system for our communities.
Thanks, Matthew. So it should be the lot. I mean, I will say, if you go back, I know you like looking at the detail. If you go back, I think since I've been on this committee since 2015, I think you will see, I think we're about 5 or 6 strategies on since then, from 2015. But thank you for that. There is a bit more reassurance. I suppose I could ask Lawrence and Darryl about, the staff survey was better. It wasn't fantastic. 1 or 2 or 3% is not fantastic, is it? I.e. the press release. But from what I'm hearing, the Make Ready Centre is a brilliant asset in Medway. And I did ask Ray, and I'm going to ask you again, it would be good for the committee to have a visit to that. I think it'd be really good for us to come along. It's very hard to get through those gates, I can tell you, especially of a late afternoon, evening. But the committee would love a visit to that centre, and I love the investment into Medway for that, and so we really do appreciate that. But just finally from me, from a morale point of view, maybe Darryl and Lawrence as well, but from a morale point of view, not just because of the building, but are your staff feeling more confident with regards to the structure change up the top?
So I think the answer is yes. I think, to echo what Matt was saying, there generally has been, boots on the ground, level engagement, staff coming in after their shifts, in pay time, having pizza, talking about what the future of the ambulance service looks like. And I've never seen that before, if I'm being completely candid. So there has been a real shift change in terms of, our paramedics or frontline clinicians having a real say on the future of the organisation. In terms of our new site, you're more than welcome to come and visit, by the way. That's something we can sort out very easily. In terms of the site itself, anyone that's been to the old site will know that there was no room for training, there was no room for a debrief, there was no room for occupational health. We've got all those things now, and they've been fundamental in some of the improvements and bringing across what made the old site to the new site. And I think there's future opportunities in terms of sharing training with colleagues from MFT and MCH as well. So as you said, there has been improvements in staff survey across the trust, more so in Medway, and as much as I'm proud of that, we recognise there's still a lot more to do.
Thank you, Lawrence. Thank you. Matt, do you want to come back briefly?
I think just want to make a comment on the staff survey. We see the staff survey improvements as significant because what you normally see, or what we've seen previously, what NHS has seen previously post a challenging CQC inspection is a deterioration in staff survey results. Now, actually, for the 4th consecutive year, what we've seen is over 60% of our workforce have responded to the staff survey. And we've seen significant improvements across all 9 domains. I appreciate within the media, I think it was presented as 2 or 3%. Actually, if I just, and I've got a couple here, if we look at job enthusiasm, it was 5 to 6% increase. Patient care was 8%. Psychological safety, so how people feel, they can speak up and footsie process, 8%. And actually recommending CCAM both as an employer and as a healthcare provider up by 10%. So I just think usually you see a flat line and you see a deterioration. Actually what we've seen is an uptick as we've moved through the improvement journey. So I just found that noted.
Let me make it clear. I mean, I think it's a really good improvement. And it was your press release, it was your own press release that was stated. Now, I wasn't reading other press, but it was a real big improvement. So I think for us, all members here that have seen you on the journey, it's so reassuring to see you doing such a fantastic. I mean, you've always done a fantastic job, and I think members would agree with me. The ambulance crews in the ambulances on the ground do an amazing job, and I don't think that was ever doubted. It was always the cultural thing behind that was the issue, and I think it's reassuring for all of us to see that move. Darryl?
Yeah, I'm following on from what Lawrence and Matt have both said. The improvement in the culture is recognised externally by applicants, because we see after negative press, things such as the negative CQC report, that there is a downturn in applicants for roles all the way across the organisation, and we've seen that starting to pick up over the last year. So those numbers increase. So as the word gets out, as word of mouth from staff and things in the press as well, that is really picked up on by the public. So we're actually back in terms of recruitment in certain areas to where we were 3 or 4 years ago. So I think that's another real positive indicator.
No, it is. Like I say, I think you do a great job, and please take our thanks back to the team from this committee of all the work you do. It's amazing. And we may take you up on what you've offered, Matt, with regards to that, more about that strategy and more about what it means, and maybe around the partnership element, because I know we could go on all night asking about whether that partnerships have got better, and I think maybe not for now, but from what I'm hearing, they are getting better. So
I think just one comment. I won't go into it now, but I think just to clarify and to build on what Darryl said, so our board met in February. We had 3 options that are within the paper. So the first option was CCAM steps back to being a core emergency ambulance service. Option 2 was actually we step into a care navigation space. So we build on, whilst delivering the core emergency ambulance service, actually how we best support our urgent patients through a virtual response type model. And option 3 was how we integrate and deliver partnered services. Now, actually, the appetite and following discussions with system partners was perhaps we're not ready as a system for CCAM to step into delivering those partnered services. We need to do the basics right and understand our role and what our purpose is within the systems. But just to reassure, I'm very happy to come back. That care navigation piece, the option 2 that we're working up, and as Darryl's mentioned, the strategy is on track to be published externally in Q1 of the new financial year. Is very much about collaboration, the whole ethos, the principles around collaboration. And as I say, just to finish with, again, it's been co-designed throughout. So our systems are fully bought into our strategy and very supportive.
Thanks, Matt. And it might be very helpful to always, in any briefing papers or anything you have like that, we're always, Michael and the Democrats, we're not Michael after tonight, but I will rub that in again. But our Democratic Services team, as a committee, we're always happy to have any briefings you have. I get your newsletter, that's good, but briefings would be beneficial. Anything that you have, the more you keep us informed as a HAS, the better it is really in the long term. So, okay, Vice Chair.
I move that we note the report and ask for a further update in March 2025.
Although we might come back to Matt on his work. Thank you very much for all your help, and I'm sorry to keep you waiting this evening. Is that seconded? You thought I forgot. And is that agreed? Agreed. Thank you very much. Good evening, guys. Thank you. Okay, we move on now to item 10, Council Plan Performance Monitoring Report. Leanne, I hear you're introducing this, so obviously we've read all the detail.
Thank you, Chair. Given the lateness of the hour, what I would say is you would have seen a mixed picture, some good progress in terms of the greens, more work to do on the reds, but there's significant narrative there to let you know what's what and how we're moving with that. So I don't intend to go through every one, Chair. If there's any questions, I'm prepared to answer those, of course, or people can catch me after the meeting.
Any question, members? Okay, no question. I suppose the only one item was around the added additional pressure of the adult social care budget, but that's we can always put brief on that, can't we? Okay. Okay, Vice Chair.
I move that we note the Q3 2023-24 performance against the measures used to monitor progress against the Council's priorities, and also note the Q3 2023-2024 strategic risk summary.
Is that seconded? Seconded. Is that agreed, members? Agreed. Thank you. Okay, we'll move on to items. I understand, Dave, your items 11 and 12 you're taking together, and I don't want you to feel that we're rushing you just because it's 15 minutes over my usual time. So please don't feel any pressure.
No, it's fine. I wasn't aware I was doing both together. I can do that. Okay, so the first report is the third round of the capital monitoring. So that relates to the schemes within the remit of this committee. This report was presented to Cabinet on the 13th of February. So the overall result of the third round of monitoring was a projected underspend of £32.6 million across the council, although none of that is actually to schemes that were within the remit of this committee. Moving on to the revenue report. So again, this was just to summarise, is the position for the third round of revenue monitoring. Again, went to Cabinet on the 13th of February. The result of that process is actually projected overspend of £3.59 million across the council, of which around 8.5 million relates to services that are within the remit of this committee. That's set out in section 5, starting on page 131, I think. Just a quick note on kind of reserves. So changes to the level of general reserves are set out in section 7. Work has identified 5.727 million in earmarked reserves that are no longer required for their original purpose, and council has now agreed that they can be declassified and moved to general reserves. So that brings the overall kind of level of general reserves up to 15.882 million. However, should the round 3 projection of 11.35 million materialise, the council's reserve balance would only stand at £4.5 million, which is some £5.5 million below the kind of minimum level set by the Section 151 officer. Happy to take questions on either report.
Thank you, Dave. Any questions on items 11 or 12 from members? No. Okay, so Vice Chair, for item 11 first, please.
I move that we note the results of the third round of capital budget monitoring for 2023-24.
Is that seconded? Seconded. And agreed, members? Agreed, thank you. Vice Chair, can you do item 12? Obviously, you don't have to read all of it. You can just ask people to ask the A, B or C as the recommendations laid out.
I move that we A, note the results of the third round of revenue budget monitoring for 23-24, B, note that the Cabinet instructed the corporate management team to implement further urgent actions to bring expenditure back within the budget agreed by full council, C, note that council agreed to declassify the following amounts currently held in earmarked reserves and transfer them to general reserves, notably 4 million held in the South Medway Development Reserve, 1 million held in the Transformation Reserve, and 727,000 held in the Mosaic Forms Reserve.
Is that seconded? Seconded, Councillor Printer. Is that agreed, members? Agreed. Thank you very much, Dave. Thank you very much for that. Thank you. Work programme, your last work programme, Michael.
My very last one. Happy to take any questions on.
Nothing from members? I think we just had the, we've just brought up, Michael, the urgent treatment centre. We're going to, you only received this yesterday and members got this, so it was pretty poor that this has gone to HOSC and we haven't seen any of this, so we're bringing that up, aren't we? And I will say under the work programme, members did go to see Ruby Ward. There were members that went to see Ruby Ward and I think was very impressed. It was a very good, I know we would have liked it in Medway, but it is a very good facility and will provide a very good service, I think, for those attending. Okay, thank you, Michael. Is that Vice Chair? Work programme.
I move that we agree the work programme as set out in Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text.
That's seconded, members? Okay, is that agreed? Agreed, thank you. Thank you, members, for a really good night of good questions. As per usual, I think we certainly made all of our guests, we put them through the mill with our questioning, so congratulations. Okay, thank you and have a very good evening. Good night, everyone. Good night.